Hello, please take your seats. We'll be starting in a minute. Welcome, everyone, to this highly anticipated event, the Health Policy Plus End of Project Learning Exchange. My name is Frances Ilika, and I have been very fortunate to work with many of you over the course of this project, working for Palladium as the Nigerian Country Director for Health Policy Plus, and on behalf of all the partners of Health Policy Plus, I am excited to welcome you all to what will be a day of taking stock and celebrating our work at the conclusion of this 7-year global health project funded by USAID and PEPFAR. We promise you a day of revisiting proud moments, hearing from our colleagues working across the field, reminders of the progress made, details that make policy work, structures, frameworks, and the grit of what it takes to do this work. We promise discussion of what is to come and food for thought on the opportunities and challenges ahead. Over the 7 years of Health Policy Plus, we have together been part of a project that is about many things. It's been about language, not how we say the words, but what underpins them and needs no translation. Equity and that firm belief that every life is worth saving. Dignity, inclusion, and achievement. It's been about numbers. Numbers of policies, numbers from data, numbers visualized in digital apps and informatics. It's been about locally led development, about attention to adaptation for context, about tradition, innovations, and new norms, about recognizing and standing beside to support the local wisdom that we encounter every single day. About the fact that really all progress is local. It surely has been about COVID. It's about an exponential spread that threatened and still besets the globe. It's about stunning and heroic efforts from many of us here today. It's about learning and changing on the fly with little time to look back or even stop. And now we hope it's about a dawning light. And yes, it's about money. Billions mobilized with support from major donors, millions from local governments and private sector partners. But mostly, deeply, and essentially, it is about people. Youth, traditional leaders, faith leaders, babies, mothers, workers, policymakers, the collective wisdom and dignity of all lives lived. Lived by you in this building, lived by the people we lift up in communities across the world. So today, we'll have a chance to hear and talk together in all that we are about. The impact that has been made in communities and in the lives of people who now look at a more promising future filled with opportunities. You would notice that there are QR codes on all your tables around you. If you scan these codes using your phone or tablets, it will bring you to the HP Plus End of Project website where you can find resources and briefs, reports, and other materials that we'll be sharing today. Before we get started, I would like to remind everyone in the room and listening into the live stream, because we have people from all over the world listening into the live stream, that will be hosting a virtual innovations cafe tomorrow morning from 9 a.m. to 10 a.m. Eastern Time. And you're highly welcome to that event as well. This Innovations Cafe will feature a series of short interactive introductions on HP Plus tools, models, and approaches. You should all have received a link to this event during your registration, and we look forward to seeing you there. In your folders, you would also find a handout of today's agenda. The morning's agenda is displayed on the screen, and you would have received the link. We are honored today to have Melissa Jones with us to provide keynote remarks. Melissa Jones is the Deputy Assistant Administrator of USAID's Bureau of Global Health. And now, to start off the day and welcome you all, we'll be hearing video remarks from Atul Gawande, who is the Assistant Administrator for Global Health at USAID. We want to specially thank you, Atul, for providing us with these video remarks, even though you couldn't make it today. Immediately after this video, we invite Veena Menon, a Health Development Officer and the HP Plus AOR, to come and make some opening remarks. Please enjoy the video.
Hello, everyone. I'm really sorry I can't be with you today. Congratulations to Health Policy Plus on an impressive 7-year run. I want to begin by thanking Palladium and the HP Plus Consortium, especially our country-based teams and government and civil society partners. We truly value this collaboration to improve health everywhere through evidence-informed policies. When USAID designed Health Policy Plus more than 7 years ago, we envisioned a global project that would support local partners in leading their development agendas, that it would foster an environment of coordinated action between civil society and local governments, and that it would promote the development of sustainable finance approaches. With HP Plus's focus on stewardship and accountability, it has been at the forefront of locally led development. From Guatemala to Uganda to Pakistan, the project successfully partnered with local leaders, everyone from youth advocates, Indigenous women, faith leaders, to policymakers. And it did so to strengthen connections and drive citizen-led change and policy action. For example, in Malawi, HP Plus and Feed the Future supported youth clubs in the Mangochi district to officially register as a cooperative and continue to grow their honey production business. These clubs are now investing a portion of their revenue into expanding health services for young people. And I would call that a great example of inclusive policy in action. In Madagascar, advocates relied on HP Plus generated data and advocacy training to integrate a tax exemption for contraceptives into the country's finance law. That is a huge policy win that will increase access to affordable family planning products for many more women and couples across Madagascar, and will encourage private sector engagement in family planning service delivery. I also want to commend HP Plus and partners for remaining undeterred by the global pandemic over the past 2 years. You have evolved and you've adapted as to do whatever's needed to sustain policies that would keep family planning and reproductive health, would keep HIV, and keep maternal and child health service delivery activities all on track. In Guatemala, HP Plus and partners assisted civil society networks in leveraging social media for COVID-19 messaging. Thanks to an HP Plus database of contraception indicators, a youth-led watchdog group found that the use of family planning in their communities had declined during the pandemic. And so that group used that data to develop a social media campaign calling for the continued offering and use of family planning and reproductive health services. This was work that reached thousands of Guatemalans. In El Salvador, HP Plus worked with local partners to strengthen COVID-19 emergency response by facilitating the delivery of ventilators, training healthcare staff on the correct use of those ventilators, strengthening lab capacity, and supporting online registration for vaccines. In part due to these efforts, vaccines for thousands of people across El Salvador were enabled. We recently developed a vision statement for our Global Health Bureau here at USAID, and it reads, "We are an inclusive, agile, and innovative team, co-investing resources and expertise with communities and countries to advance sustainable public health approaches, improving and saving lives everywhere." Your approach and your accomplishments are inspiring examples of how this vision becomes a reality. Your work demonstrates the essential role of policy leadership in a strong enabling environment in supporting the delivery of effective and equitable primary health care. Thank you to all of you for your dedication and commitment. Today is an opportunity to take stock, engage in dialogue, and look to the future. So I hope you have a thought-provoking and energizing day. Thank you.
Hello, everyone, and welcome. Can everyone hear me? There we go. Better. So thank you to Atul for those wonderful words and for that wonderful message. With such a large global project operating in nearly 50 countries over the course of 7 years, it's difficult to showcase everything done in collaboration with our local partners. When I see the numerous achievements of the project, I'm reminded that these achievements represent thousands, even millions of men, women, and children, and families who've positively benefited from policy change and implementation, the work that HP Plus has undertaken. Whether it's a new health insurance scheme that extends coverage to people living with HIV in Cambodia, or an insurance plan that enrolls community members in Osun State, Nigeria, for the first time, each of these advancements are providing care that wasn't feasible or accessible before. We know it's not simply about enacting policy. Health Policy Plus was designed to ensure that a constellation of approaches is addressed holistically. Countries need better health policies. They also need to address sustainable financing and governance structures to implement these policies. Advocates, whether at the community level or down the hall in the Department of Health, need evidence and platforms to make a case for action. And all players in the health system, whether it's providers, clients, or the government, need to build trust amongst themselves to achieve stewardship, good stewardship, and accountability. They have come together under the Health Policy Plus to address health reform needs, as we have evidence in the last 7 years. Expertise in policy for family planning, HIV, maternal and child health alone is, of course, not enough. The project has partnered with local individuals, organizations, and institutions to listen to their priorities, understand their challenges, and work together to generate evidence, develop new approaches, and remove implementation barriers. And in that engagement strengthens the capacity of the partner to take it forward. So we're very proud of everything that's been achieved in these last few years. Thank you to Suneeta Sharma for her steady leadership. A big thank you to the country teams who are here with us today. I know many are listening in on the live stream, including our mission colleagues who couldn't be here in person. Your work inspires me every day, and together, all of you, and with our local partners, have made remarkable progress to improve health outcomes worldwide. I'm now very pleased to introduce Melissa Jones, USAID's Deputy Assistant Administrator for the Bureau of Global Health. Melissa is a senior Foreign Service officer and a leading voice in the agency, especially as we prioritize locally led development. Welcome, Melissa.
Hi, everyone. It's really good to be here in person. Isn't this just strange? I mean, frankly, I have been overseas for about 15 years. I've come back, and I've only been in the Ronald Reagan building, I think, twice in the last 15 months. It's quite strange. So, good morning. And for those who are tuning in online, good afternoon, good evening. I am pleased to join you today on behalf of USAID's Bureau for Global Health. It's wonderful, wonderful, wonderful to see all your faces. Like Atul, I want to thank the Health Policy Plus country teams and partners. Your partnerships, your expertise, and your ability to foster local networks and connections, and your unique understanding of the local context all help make the project what it is and are critical to its success. I, as a Foreign Service officer, have relied on many of you to make that connection, and I'm so thankful for those who are here today online. You know, this is a real pivotal time for USAID. The agency is further committed in making U.S. foreign assistance more accessible, equitable, and responsive. And we are doing this by shifting leadership, decision-making, and funding to local actors. That is government, civil society, and the private sector. And I am thrilled that these are also the core principles of HP+. As you all will hear today, HP+ worked with partners in 49 countries to develop and implement better health policies for family planning, reproductive health, HIV, maternal and child health, and now COVID-19. As USAID's flagship health policy project, it has helped to make policy development more inclusive, context-specific, realistic, and focus on achieving equity. I can't stress that enough. Focus on achieving equity. For example, HP+ country teams have assisted local actors to develop, adopt, implement, or monitor 187 context-specific policies and strategies. Each adopted policy is a sign of political will, but as many of us know, adopting a policy is just one step. Governments must also implement and fund those policies, monitor them, and update them as needed to improve health outcomes. To implement those policies, HP+ has been there as a partner, as a catalyst, really, to introduce a systems approach to mobilizing resources for health and ensuring resources are allocated in a way that will improve health outcomes. The project partners with governments to develop plans that align incentives, create structures and mechanisms, and provide the resources to fund programs and services. HP+ and its local partners, decision makers, program implementers, and advocates help put these policies into action. For example, over the course of the project in all its countries, HP+ helped mobilize nearly $500 million in domestic resource mobilization for health. That is a huge feat. With HP+ support and financial planning analysis, health department staff successfully made the case for these funds within their own ministries and also with other key stakeholders. In fact, at every step of the policy process. HP Plus engage local stakeholders. This means engaging local youth advocates, women's groups, traditional leaders, and other groups who have traditionally been excluded from decision-making processes. The project helped these champions to keep their local governments accountable for implementing policies and supporting them in keeping community members aware of these policies. For instance, in a country that's quite dear to my heart, Bangladesh, where garment industry is the larger employer of women, HP Plus engaged with garment workers to make the case for adding high-quality family planning benefit package, creating a pathway for potential millions of women to have more contraceptives options to participate in the workforce. And then across the world in Guatemala, networks of advocates are now calling for strengthening and decentralized network of health clinics that will allow indigenous women to access contraceptives in their rural communities. Again, the power of the local voice, the power of communities, and that power has been really fostered by all of you. Again, want to acknowledge those that are on the live stream. We appreciate you so very much. We have the opportunity to hear today from the country teams who helped achieve these remarkable outcomes and have the expertise, knowledge, and learning to share. Today is a great opportunity to learn about the tools, the approaches, and innovations under HP Plus that have equipped local communities to steer the journey towards improved health services and better health outcomes for all. I'll close by saying thank you again to the country teams and partners for making the project all that it has been. Success at USAID rests in large part with our strong partnerships and the partnerships with all of you. I also want to thank everyone for joining today, and I look forward to hearing how today's discussions helps inform all of our efforts to make health policy and financing more sustainable and more equitable as we move forward together. Thank you so very much.
Thank you, Atul, Melissa, and Veena for your kind remarks. I want to take a moment to welcome everyone who has joined us in person. I think for many of us, it's like after 2 years, 3 years, this is first public event we are attending. I'm honored that you chose to be here. To our Palladium America's leadership and our outstanding AOR team and mission representatives, Veena Menon, Bev Johnston, Irene Naganda Kumana, and CDCC, and all our USAID colleagues, thank you for all you have done to support HP Plus, and thank you for joining us today. For those joining us by live stream, I want to welcome you. I know this is a large time commitment. We truly value and appreciate your interest and willingness to log on. It has been my immense honor to lead the Health Policy Plus project in this last 7 years. For me, like so many of us, this work is personal. Growing up in India, I saw health inequity firsthand and how disparities in access and agency affect the most vulnerable among us. This team has a diversity that informs our work. We represent 50 countries and speak 38 languages. I'm so proud to work alongside all of you. Your insights, perspectives, expertise, and relationships have fueled this effort from the first day. Need to play the video, I guess. The accomplishments we will present and discuss today have been achieved because of the many, many people who have contributed to the success of this project. I would like to take a moment to recognize the staff and partners that we lost along the way. Their loss is profound, yet they continue to inspire me. I see their dedication and passion in all of you here today. And among our partners and communities, they will never be forgotten. HP Plus had a significant global impact. So far, we have collaborated with nearly 1,700 partners across 49 countries to achieve more than 2,000 results. This includes the mobilization over 465 million in domestic health resources and 1.4 billion mobilized by countries from the Global Fund and other donors. We have supported 187 policies, including laws, regulations, strategies, and operational guidelines, policies. We have helped facilitate the achievement of these results with the focus on localization and capacity strengthening, and with the leadership of our local teams, country partners. From the start, HP Plus has continued to accelerate, implementing activities, achieving results. This has remained true even during the COVID-19 pandemic, due to our staff's ability to pivot and adapt. As we have all experienced, the global pandemic has impacted everything we do. As local partners ramped up their direct COVID-19 response, we worked hand in hand to strengthen and guide their efforts, which are rapidly changing every day. From building online vaccine registration sites and understanding COVID-19's impact on health budgets, to training healthcare workers and producing guidance on vaccine administration. We have been there. Our established relationship with ministries of health at national and local levels has allowed us to nimbly adapt, respond, and support efforts and local needs as they evolve. We are also working to ensure continuity of essential health services, family planning, maternal health, HIV, even as attention and resources are pulled away to combat the virus. You will hear directly from our experts during our COVID panel later this morning. It's been an impressive effort, and I'm so proud of this team. I think you will be too. Policy work is the backbone of everything we do. Well-financed and functioning systems, high-quality service delivery, equitable access to care, improved health outcomes, it can all be traced back to policy. Policy matters. One example of policy's reach is costed implementation plans for family planning, or CIPs. These are multi-year roadmaps designed to help countries achieve their own family planning goals. So far, HP Plus has helped 14 countries develop 19 CIPs. Through this work and other efforts, countries are seeing increases in the use of modern contraception and a decline in maternal deaths. we got news of some of other really major achievements last week, and I'm so delighted to share those with you. Mali's Ministerial Council voted to approve a decree formalizing the status of community health workers as an official cadre of health personnel. The adoption of this transformative policy is the culmination of 7 years of HP Plus's partnership with the Mali's Ministry of Health. It will protect the status and rights of more than 3,000 community health workers and ensure their stipends are paid with domestic rather than external funds. Also last week, after years of CSO advocacy, supported by our team in Guatemala, the country approved a law which will allocate annual payments to the country's 23,000 nationally registered traditional midwives. Promoting evidence-informed decision-making is crucial. Stakeholders are now better equipped to generate, synthesize, and use data to inform advocacy and decision-making. Working with local partners, we have helped develop and apply 76 methods, tools, and approaches. Now we witness the strengthened capacity of our local partners to use those tools to generate and apply their own evidence. This has helped elevate local voices and contributed to global advocacy efforts. Through the White Ribbon Alliance, over 1 million women and girls from across 114 countries have told policymakers what women want. In terms of reproductive and maternal health services and outcomes, local partners are taking their rightful seat at the tables of global fora, like the Reproductive Health Supplies Coalition and the World Bank's Sustainable Financing discussions. Digital tools and strong health information systems are vital. Online dashboards and mobile apps strengthen social accountability and decision-making. A properly functioning health information system gets vital information into the right hands at the right time. The now resilient and regionally owned West Africa Health Informatics team has increased local informatics capacity across 15 countries, improving emergency preparedness and response for over 400 million people. As we saw earlier, the government partners have mobilized significant resources. Governments must optimize resource allocation, management, and use to improve efficiency, deliver impact, also achieve equity. We have supported countries in elevating health and family planning in fiscal space, engaging ministries of finance, strengthening public financial management systems, designing and implementing health financing strategies and mechanisms, exploring blended financing opportunities, and strategically purchasing services to increase health access, improve quality, and reduce out-of-pocket expenses. The domestic and private health resources our country partners have mobilized are expanding health services and strengthening health systems, supply chains, and the availability of health commodities. It has made such a big difference in these countries. With the support of the Sustainable Financing Initiative, Kenya has strengthened the capacity of over 800 national and county health staff in program-based budgeting. It was a great initiative to work with the Ministry of Treasury, and there were a lot of successes at national level, county level, in terms of mobilizing resources. And also, Kenya has really very specific, really important examples of providing financial protection and enrolling clients in different insurance programs, and Linda Mama, which is maternal health policy implementation, where women can get services free of charge and really have access to high quality services there. Part of HP Plus's work is also to ensure governments are good stewards of health system, acting transparently and being held accountable for their actions. HP Plus works to empower citizens and civil society networks to work collaboratively with the government throughout the policy to action cycle, while also developing the capacity of the government to meaningfully engage with citizens and civil society. Much of this work has been through our engagement with local organizations with a focus on joint accountability. Guatemala established a National Contraceptive Security Commission. This group is made up of government and civil society representatives working together. Later, the commission helped establish a network of similarly structured subnational committees to bring accountability and context-responsive solutions to the local level. These local governance structures aim to ensure equal access to family planning in some of the country's most hard-to-reach areas. Their impact has been profound. In one of these communities, the number of family planning users increased by 46% in just 2 years. Nationally, indigenous women's use of modern contraception is on the rise, having more than doubled. We have learned a lot over the past 7 years. Alongside our country partners, we have established best practices and developed new approaches and tools and innovative solutions. In the spirit of continuous learning and adapting and knowledge management, we have shared them widely through webinars, project publications, and regional and global conferences. We hope you will plan to join the virtual Innovations Cafe we are organizing tomorrow. We'll share some of the tools we have developed, new approaches, methodologies. It's going to be very interesting. And of course, all these accomplishments and innovations I have shared today rely on the increased capacity of our local partners. Capacity development is integrated into everything we do. It's not about one-off trainings, but about working side by side with local partners to find solutions and design new processes and approaches. They are always in the lead. They are closest to issues, know what is needed to achieve improved health outcomes. So we listen, respond, and offer new technologies, tools, and solutions that are intentional and tailored to the local context. Video?
Nothing was working. There was no coordination, the governance was poor, and we were not able to achieve what the positive health indicator should be. But between that time and now, things have begun to change with the intervention of HP+. It's not enough to say the law has been passed, but has it come to reality? Has it been operationalized? That was a challenge. And if not for the intervention of the HP+, we might still be flagging on that.
What had been done with HP+ has set a new standard for NI, for Balitbangkes researchers, specifically in scientific writing. Thank you, HP+.
Many thanks to HP+. I used to say, anywhere I go, that HP+, the heartbeat of BACPF in Osun State.
What I would say, conclusively, is that we have learned self-reliance through the work of HP+.
Para nosotros el apoyo de USAID, GEP y de Palladium ha sido de muchísima contribución a la institución, porque no solo respetan pues, la institucionalidad, sino la independencia de la institución.
Linda Mama has been a program that has taught us in Kenya and shaped the roadmap towards universal health coverage. With the partners like HP Plus, developed all the necessary guidelines and all that.
We know that doing the data analysis, the decision-making, the policy work is a long, hard slog, but it's really critical to ensuring that all of this work translates into improved health service delivery on the ground.
So our partners are driving change. We know it's a very difficult environment, pandemic, number of different challenges, but they're making progress. They're moving toward equitable health system. And these achievements come from their tireless commitment and that of USAID and our teams collaborating day after day to improve the health and well-being of their communities and their countries' health systems. I know one of the quotes we had from Dr. Menon, she's here with us attending this from Kenya. Thank you, Dr. Menon. So I want to thank USAID and all our consortium partners. And now I will turn it back over to Francis. Francis, thank you for leading us through our proceedings today. We are so happy to have you here, and also our country team leaders. They are the real policy leaders, and really so proud to work with all of you. I feel so fortunate to be part of this project. Thank you.
Thank you very much, Suneeta, and thank you so much to all the excellent speakers this morning. We want to thank Veena, Melissa, and all the people that have spoken, including the people that gave us those excellent quotes. So at this point, we want to have a short break, and we'll be reconvening by 10 a.m. So during the break, there's coffee at the back, and feel free to watch the things we have on the screens over there and to have conversations based on what you've had so far.
Around the world, a woman dies every 2 minutes from preventable causes related to pregnancy and childbirth. Giving birth without the assistance of a skilled provider significantly increases these chances. In Kenya, more than 1/3 of pregnant women give birth outside of a health facility and without the assistance of a skilled birth attendant. But a new publicly funded health scheme in Kenya is turning the tide, providing basic health services to pregnant women and infants for free, saving the lives of women and children across the nation.
Some are not coming because of financial problems. Because you come here, you are told, go and buy this, go and buy this, go and buy this.
Sahi sina hayuko karibu, hatushughuliki. Hasa hata nilikuwa nashindwa, hizo pesa nyingi hizo nitatoa wapi za kujifungua?
In 2013, advocates pushed Kenya's President-elect Uhuru Kenyatta to honor his campaign promise to abolish user fees for maternity care in public health facilities. Doing so, they said, would save at least 18 women every day from dying in childbirth. Within months, the government introduced its free maternity program and committed $42 million to fund the program. 3 years later, the government renamed the program Linda Mama, expanded it to include postnatal care and a year of well baby visits, and transferred it to Kenya's National Health Insurance Program. Now, Linda Mama is helping more women access healthcare long-term by encouraging its recipients to enroll in the general insurance scheme.
Wengi walikuwa wanapata shida sana kwa sababu mtu utapata hana pesa, anaogopa kuenda kwa hospitalini. Kwa mfano mimi nimefanywa CS. Ningekaa pale kwa nyumba, maybe singesaidika mimi pamoja na mtoto.
Because of Linda Mama, facility deliveries are steadily increasing and maternal deaths are declining.
It has been a fantastic project because it has done great things for these mothers and their babies.
Access to skilled delivery is actually improving. In Mombasa, before the introduction, we were having around 14,000 deliveries. The subsequent year, actually it increased to almost 19,000.
At Mombasa's Port Reitz Sub-County Hospital, more women are coming to deliver their babies. Maternal deaths at the sub-county have dropped by 64%, and newborn deaths have dropped by 87%. As more women deliver their babies in facilities, health workers can offer them additional services like family planning and well baby visits that can improve the health of the entire family.
Na hapo kwa hospitali kuna vitu huwa wanapea watu kama nguo, cotton, sabuni, vitu nyingi, mabeseni na leso. Mtu akihitimu miezi 7 nikijifungulia hapo tena wataja kunipa hizo vitu na wanapeananga mpaka mtoto atakapofikisha mwaka mmoja.
For all the mothers after delivery, we educate them on family planning, the importance, the methods. Then after 6 weeks, we advise them to come to the postnatal ward to pick a method of their choice.
These women, they have a chance to be in the health facility. You know, if they've been not coming, they would not have a chance, maybe somebody to talk to them about family planning. It has really helped.
Tremendous progress has been made, and Kenya could see even greater results by ensuring facilities are prepared to meet the increased demand for maternal health services.
We need to expand the unit for better services for the mothers. We need to be empowered with enough manpower, enough skills, so that we can manage this mother to the best of our level.
More than 1.1 million women across Kenya have received life-saving services under Linda Mama.
Lakini wakati huu kuna change yenye inaendelea. Wakati huo na huu kuna mabadiliko makubwa sana.
Hello everyone, the next session starts in 1 minute, please.
Tunapata usaidizi kushinda ule wakati wa nyuma.
Advocates, policymakers, and healthcare workers have made these changes possible. As Kenya continues to improve its health system, more lives can be saved as we work together. Better policy for better health.
Welcome back, everyone. Please, may we get seated? Thank you. I hope everyone had a chance to enjoy some coffee and fresh air during the break, and that those of you who were in the room probably caught a glimpse of the Linda Mama video that was showing during the break. And this is a publicly funded health scheme in Kenya. And during this next panel, you'll get to learn a lot about this excellent intervention that was locally led and responded to local needs. This video ties well into our next session this morning. We're having 3 mini panels focusing on the challenges, opportunities, and future directions in locally led health policy, advocacy, finance, and governance. And we're very fortunate today to have a panel leader, Janet Fleshman, who is a HP Plus consultant. Many of you may know her from her role as Senior Associate with the Global Health Policy Center at the Center for Strategic and International Studies. Janet is a prominent voice on women's global health and rights, gender, HIV/AIDS, US policy, and she's the author of the beautiful brief you have in your folders on catalyzing localization. Janet, over to you, please.
Thank you so much, Frances, and welcome to you all. What an honor to be able to moderate this panel for exactly what we came here for, to hear the voices of the people on the ground who are moving forward the efforts of HP Plus and localization in such interesting and concrete and important ways. So we hope to learn some great lessons from them today. Before I introduce them, let me just say a couple of words about this moment and about the paper that Frances just referred to. I think we can all agree this is a pivotal moment for the new Biden administration and for USAID as it formulates a new vision for sustainable global health and development, championed, of course, by USAID Administrator Samantha Power, who is focused on the importance of locally led and inclusive development, which we are referring to as localization. So this is an aspiration to make US policy and US foreign assistance more accessible, more equitable, more responsive by shifting leadership, decision-making, and funding to local actors. And that means governments, civil society, and the private sector. Previous US governments have pushed forward their own views of promoting country ownership, but right now this is a really urgent conversation. It's happening amidst a pandemic, a global reckoning around structural racism, social determinants of health, decolonization of global aid, and the power imbalances inherent in donor-driven development. So this requires a different kind of engagement with governments, with civil society, with national and subnational actors, pulling in the private sector to really foster an enabling environment so local actors can truly lead and civil society is really involved in ensuring the accountability and identifying the needs and defining the priorities that are so important in their societies. And taken together, these form the components of and the foundation for health policy development, advocacy, decision-making, civil society engagement, and domestic financing. As you've heard from Suneeta's remarks, HP Plus has learned a lot from its engagement with partners across the world, working with local actors to design, apply policy, advocacy, financing, and governance solutions to global health challenges. And in the paper that you have before you, we identified 6 components that we thought were important to consider to catalyze localization. And quickly, because the paper will give you some of the HP Plus country examples that indicate some of the lessons we learned on that. The first one is making technical assistance for capacity strengthening responsive and demand-driven. The second is strengthening and diversifying the local marketplace for expertise by supporting local professionals and local organizations. Third, ensuring equity through participation and leadership from women and girls, indigenous communities, LGBTQI people, youth, and other marginalized groups. Fourth is improving the use of data and measurement to propel performance and equity. Fifth, expanding mobilization of domestic resources and the engagement of the private sector. And the sixth, building on joint accountability for inclusive and sustainable results. So this is an ambitious agenda, and implementation is going to face many challenges. And we have to be honest that one of them is the inherent tension of asserting that local actors should be driving the agenda, and the reality that USAID and the US Congress may not hand over all the reins to local actors. It's also important to recognize that sometimes localization doesn't ensure equity, and we'll have to be very careful to see where local biases and norms and attitudes may conflict with equity and gender transformative approaches. And finally, USAID itself can be a barrier, given onerous compliance and reporting requirements, which sometimes make it complicated to get funding directly to local actors. But even given this and all the challenges we face, this vision holds real promise for advancing partner countries' needs and priorities and transforming the global health landscape through a more equitable, collaborative, and sustainable approach. So with that, let's turn to this panel. I'm going to briefly introduce them. This panel is going to be focusing on creating an enabling environment for policy, advocacy, financing, and governance through localization. And I'm going to quickly introduce the three speakers that we have. First, you've already met Frances Ilika, but she has expertise in health system strengthening, health financing, governance, human resources for health, and service delivery from both the clinical and public health practice. She's worked across several international projects and has facilitated the formulation, legislation, design, implementation, and monitoring of several strategic health systems working toward universal health coverage. She has a degree in medicine from the Nnamdi Azikiwe University in Nigeria and a master's degree in public health economics from the London School of Hygiene and Tropical Medicine. Next, we have David Hayoya, who is a senior health finance advisor and has served as deputy technical director for HP Plus in Kenya. He holds a doctorate in economics from the University of Cape Town in South Africa and has taught economics at Strathmore University in Kenya and healthcare systems and financing and health economics at the University of Nairobi. We have Deswanto Marbun is from Indonesia, is currently the Senior Program Advisor for Health Policy Plus Indonesia. He has 15 years experience bringing strategic government engagement, project management, and policy analysis. He graduated from the University of Manchester in development management and has since been working with NGOs, UN agencies, research institutes, as well as donor-driven projects. And finally, last but not least, Herminia Reyes, who directs the Health and Education Policy Plus program in Guatemala. She has more than 35 years of experience working in social programs, especially related to education and health, and began her career in a rural elementary school as a teacher. She's worked for international development organizations and managed several USAID projects. And in 2016, she was awarded the National Order by Francisco Marroquin, the National Order Francisco Marroquin by President Jimmy Morales, the highest honor for educators in the country. So without further ado, I wanted to open up and give Frances the first question to set the stage for us about why localization is necessary to create an enabling environment for policy, advocacy, financing, and governance. So distinct from service delivery, distinct from procurement, in this PAFG realm, why is localization so important? Frances.
Thank you very much, Janet. So when health system strengthening interventions towards policy, advocacy, governance, and financing speaks to the real needs and problems of communities, governments, local partners, as understood by them, not based on the perception of who is sponsoring or who is bringing the support. The real needs as understood by the local partners, by individuals, communities, governments. It enhances trust and it enhances effectiveness and real impact of the solutions that we seek. It also enhances sustainability, and it also enhances self-reliance, especially when this is done with local leadership and local agenda setting. So it is very important that we understand that in real practice, using a localization approach is what will make the difference between what we've been doing and what we want to do. There is a saying that doing things the same way and expecting a different result is insanity. So if we want to have lasting results, if we want to have sustainable results and self-reliance in the way we go about our PAGF, then localization is the way to go.
Thank you, Frances. And I think the best way to follow up on that is to get some concrete examples of how we can illustrate that these programs sought to further those goals. And we've heard a little bit, David, about Linda Mama already, but I think it would be helpful if you give us a sense of what did Linda Mama do that helped further localization and show the way HP Plus can be catalytic in moving and helping countries move in that direction.
Yeah, thank you, Janet. I'm very excited to be here. I think most of us have heard of Linda Mama. Linda Mama is a Swahili saying which means protect the mother in English. So it's a Swahili word for protect the mother. And this came about as a result of the current government manifesto, where they were promising to provide free maternal services to women, as well as abolishing user fees. So at that point, as all of you know, politicians will always promise things, but they wouldn't know exactly how to implement them. So HP Plus came in handy to provide the data and the evidence that now they will use to design the Linda Mama program. And part of that information was ideally providing how much it will cost to provide maternal services to all women in Kenya. And because at that point, we were actually having 18 women dying out of childbirth every day. So you can imagine every day 18 women are dying out of childbirth. And so HP Plus came in to provide that critical evidence that will then inform the government to be able to know how much they were going to spend. And the figure we came up with was about $50 million per year to actually enable the government to be able to provide that service to women, free at the point of service for women. And as you can know from now, Linda Mama is actually a flagship program for the government. Everybody talks about it. Women are very happy about it, and they are getting services. The indicators are now improving. Maternal mortality has reduced as a result of that. So we are proud of having been part of supporting the government to be able to come up with that program and to design it in the manner in which it is. Thank you.
Thank you, David. Such an interesting and important project. Lots of lessons to learn from that and the engagement of HP Plus along the way. A different example is in Indonesia. And Anto maybe can talk to us a little bit about the public-private partnership that you were involved in for maternity waiting homes.
Yeah, so in Indonesia case, HP Plus has been supporting Ministry of Health to develop policy framework that eventually lead to the development of Ministry of Health regulation on public-private partnership. So in the beginning, we realized that to develop this regulation, it has to be inclusive. It needs participation from key players such as private sector. So we involve private companies, business association, professional association, and including civil society organization to discuss and to come up with clear direction of how we can do this PPP. At the local level, we also did a similar thing, but the focus is on identifying what will be the need that can tackle the most pressing problems in specific contexts. And that's what we learned about the localization. While in the Indonesia setting, with the decentralization, the way the government runs, we need to understand that every time central government develop policy, standard of procedure, formulation to allocate resources at the central level, they promote uniformity and effectiveness as opposed to uniqueness and local-led process. And that's how we understand localization. At the local level, district level, subnational level should be allowed to interpret these central level policies in their own context. And that's what we help district level to understand what would be the need for a district level related to the PPP regulation. What is useful for the district? What kind of activity that can be funded through PPP mechanism? And that's where we come to the idea to revitalize the maternity waiting home. So localization can be interpreted differently at the central level and at the local level.
Thank you, Anto. And I think one of the examples of HP Plus working with local partners to really help elevate local voices and change the way services are being delivered can be found in the Guatemala example. And Armenia, can you talk to us for a minute about the work you've done with local indigenous women's groups on healthcare delivery?
Okay, thank you, Jenny, for the opportunity. It's a proud moment for me to share with us our experience working with indigenous groups. Over the past year, HP Plus supported the civil society leaders to become in an organization. The organization of indigenous women have different levels, national, departmental, and local level. With the intention of help them to improve their capabilities, to know, understand, and manage the policy and legal framework, to improve the volume and the tone of their voices. After they advocate to have in the country the healthy motherhood, in which they demand that must be include the rights of indigenous women. What kind of rights? The service providers must to attend in their own language, because indigenous women reject to be attended in the health services because they don't understand, and the provider don't understand what they want to kind of services receive. And this is one of right, and the provider must respect their custom of indigenous communities. For example, the women that go to the health services to have the hair delivered, it could be accompanied by their wife, traditional midwife. This, as you know, traditional midwife as a key actor at the community level. And now the public providers, the service providers know that they need to respect, to attend the indigenous women with dignity. Because and based on this achievement of the women organization, indigenous women organization, the country had improved the amount of women that now wants to have the health services and the medical attention, because they know that their rights must be respected.
Thank you, Armenia. Francis, do you want to say just a quick word? I know that you have worked, your work has been locally led from the start, but just a very quick intervention about what this looks like in your work in Nigeria.
Absolutely. Thank you very much, Janet. So in Nigeria, one of the ways that we enhanced localization was to support the government to elevate an already existing policy that was standing there and was, lying on the shelves. One of the things that we did was that we provided support across levels and across sectors to actually bring this very important policy to life. This policy is meant to draw domestic resources for providing healthcare access, especially to poor and vulnerable populations across the country. So some of the things that we did was that at the national level, there was a lot of capacity, but there was little cohesion and collaboration. So we worked to support the different agencies responsible for implementing this policy to bring them to a place of agreement, which led to the implementation of this policy. And then at the subnational level, there was a lot of capacity building. So we strengthened government capacity, both technical, institutional capacity strengthening, as well as relational capacity strengthening across board. And this cuts across sectors, including ministries of health, ministries of finance, who were responsible for releasing this funding to the health sector. Civil society organizations, communities, going out there to have town hall meetings, making the communities more responsive and more involved, building local government structures that were responsible for supervising this quality of care at the facility level and strengthening the facility level. So this was cross-cutting. It's leveraged an already existing policy and already existing systems and strengthened them, which made for acceptability and effectiveness in implementation of this policy. And certainly you agree with me that it also makes for sustainability even beyond the period that we were doing this work. Thank you.
Thank you, Frances. I wish we had all day for this panel, but since we don't, I'm going to combine, I'm going to go down the line and ask you each to talk about one, maybe two key challenges ahead, and then what do you see as the way forward? So let's start with David.
Thank you. Just to add something small before I go to the challenges, down the road as we were supporting this design of Mama Linda program, we realized that it would be better delivered through the National Health Insurance Fund. And as we speak now, women are now able to get those services, and the reimbursement to facilities is coming from the National Health Insurance Fund. That is very important for sustainability and for management of resources, because we started by having it being done directly from the Ministry of Health. And we realized that, again, when we went to support them to show the evidence that they required to provide that service, we also showed that women will have more chances, more choices if we also involve private sector. So private sector is also able to actually offer services and be reimbursed through the National Hospital Insurance Fund. That is very important because women require choices. And we supported that information to be able to have women get more choices through the National Hospital Insurance Fund. But coming to your question regarding challenges, of course, as any program, when you start, there are a lot of challenges in terms of monitoring, in terms of demand, because as you know, there are some cultural factors sometimes that prohibit women from seeking services. So even when the service is there, you find women are not going for the services. So reconciling the numbers sometimes becomes difficult, but the monitoring is on, and I'm sure with the time, with a lot of abandonment of facilities, the facilities that are able to provide services are now in the neighborhood of the women. And again, the other thing is that women are actually also being sensitized on these services, because initially they thought that although it's free, maybe they will ask me for payment. But now we are sensitizing through the government. The women are being sensitized that you don't need to go with any money. You actually walk there and you get the service. So that is also part of the challenge that is there on the government part to mobilize women to be able to utilize these services.
Thank you. Emilia.
In Guatemala, we have a specific challenge. We need to improve the number of facilities for health services in the rural area. This is very important for all people, but especially for the indigenous women. As I said, indigenous women need to receive special attention with respecting the dignity in the health services when they deliver her babies. And one of the challenges is to have maternal houses near of the facility, of the health facility, to avoid the maternal death. Because when if they live in the rural areas, it's really difficult to attend the risk of the maternal death, for maternal deaths in the rural area. We need to transport the women to the municipal level to close the health services to receive the attention that they need. This is an important challenge. This challenge affects not only women, but is very crucial to have to close the woman to the services to avoid the maternal death.
Thank you. Anto.
Yeah, let me also share how the regulation finally approved by the Minister of Health in Indonesia. One of the challenges to come up to the approval is facilitating different interests from multiple actors, private sector, business association, GSO, they have their own interests. We are lucky to work with strong Ministry of Health. With their leadership, they can mitigate any unnecessary tension or conflict during the process of the discussion of the regulation. So we are blessed to have that partner. So we ensure them that we are always beside them. But now the regulation is ready to be implemented. They need also continued support, particularly for the PPP committee, consists of individuals from Ministry of Health to run this PPP at the national level. So I think more investment to improve the capacity for the public sector, especially in reaching out to the private sector, understanding different alternative financing mechanisms such as blended finance, it is important. At the local level, of course, we are working with local NGO, then they also need to be capacitated. They have different funding stream coming to their financial resources. How to manage that? That needs to be improved. It requires a set of skills, how to organize, how to manage financial mechanism at the local level. So I think the challenge is technical capacity, the political commitment is there, and I think if we can continue support central and local government, this PPP idea, this PPP vision can happen in Indonesia.
Thank you. Francis, you've spoken about this broader approach to localization as a marathon, obviously not a sprint. So maybe you can just close it out by talking about the way forward. What does this look like?
Absolutely. Thank you very much, Janet. So the way forward is that it's very important for us to take a systemic approach to system strengthening that actually listens and adapts to the real needs as seen by the local organizations and communities. So for instance, in Nigeria at the national level, what was needed was enhancing relationships, while at the subnational level, what was needed was technical capacity building and institutional strengthening. So a system and the approach that we need needs to listen to what the real problems are, understand it, and be ready to adapt. So development partners must be open to listening to diverse views and perspectives about what is actually going to work, rather than assuming that we already know what the problem is. And just like Janet said, strengthening systems is a marathon and not a sprint. So we need adequate time and commitment to be able to invest in earning trust, both earning the trust of the local organizations and enhancing cross-sectoral trust among the different partners needed to implement these policies. We need time to strengthen capacity, and we also need time to support the implementation and adapt as necessary as we move forward.
Thank you. We're lucky there's so many people in the audience that we would like to hear from, but we wanted particularly to give the microphone for a minute to Abdoulaye Oseni from Niger, to give some of his reflections about the view from Niger about this question of localization. Abdoulaye, over to you.
Okay, thank you. My English is not full fluent, but sorry for this. But I want to share with you a local innovation in Niger, and want to hear from your side how we can make this kind of innovation sustainable. So the chief of Tessawa in Niger, named Kane Maigizo Mansour, participate in a meeting organized by HP Plus in collaboration with the Union of Traditional and Religious Leaders from West African countries who advocate for acceptance of family planning methods in the region. When Chief Mansour left the workshop, he was inspired. He brought together 152 local village chiefs and 1980 religious leaders to raise awareness of family planning issue. He set up a system of collecting millet from every household to fund family plan needs, emergency evacuation of pregnant women, and some others health issues. Over 26 tons of millet have been collected and translating into 4 million francs CFA. Because of the success of this innovation, UNFPA put also 8 million to help him to set up this innovation. So how can we make sustainable this kind of innovation and scaling it up?
Thank you, Abdullahi. We have limited time, but perhaps we could take maybe just 1 or 2 questions from the floor if anyone else wanted to ask something, and then we'll have the panel run through to address Abdullahi's question as well as anything else that comes up as part of their concluding remarks. Any questions from the floor? Okay.
Okay, so thank you very much. Not a question, but just to add on to the discussion up there. And now that I have the mic, allow me to just say appreciation to HP Plus for inviting the government of Kenya through the Ministry of Health, who I represent under the express authority of my cabinet secretary. That's the Minister for Health in the country. Also appreciate HP Plus for supporting the government of Kenya, Ministry of Health and the county governments, because we have 2 levels of government. We are devolved, national and the counties, especially as we implement the UHC agenda. Now, what has been shown there on Linda Mama, the government invests 40 million USD per year. And you can imagine without evidence that HP Plus helps us to generate where that money would be going. At least you're able to see the mothers who are delivering, the reduction in maternal, and also the neonatal mortality, because Linda Mama takes care of the women and the child for 1 year after birth. Now, in terms of sustainability, Linda Mama has also informed the implementation of UHC, especially development of a harmonized benefit package to be implemented under NHIF. That's the national, now used to be called hospital, but it's now Health Insurance Fund, because the government is implementing universal health coverage. The costing, the data has informed us, including other purchasing reforms in NHIF. So I really appreciate the principles that HP Plus works under, especially that one of sustainability, working with government. For us, Kenya, I have said the national government and the county government. Looking at the priorities that we have, yes, we have Linda Mama, now we are evolving to a more sustainable financing mechanism through the National Health Insurance Fund, and we are using that evidence that HP Plus is helping us with. Just before I sit down, let me say that HP Plus has also helped us to look at overall sustainability in terms of financing framework. I am proud to tell the people today that HP Plus helped us to develop a health financing strategy, which was launched by none other but by the head of state in Kenya on 7th of January 2022. So we really appreciate. In Kiswahili we say vyema sana. That means well done.
Well, we've covered a lot of ground, and it would be wonderful if we had all day to go into depth on all of these questions and programs. But I think I'm going to give the panelists each a minute to add anything that they want to say in conclusion, responding maybe to some of the sustainability comments that Abdullahi also asked about, and give you just a minute to wrap up. So we'll go the opposite direction. We'll start with Francis this time.
Thank you very much, Janet. So sustainability is very important, and some of the markers that we've seen in Nigeria that enhance sustainability was, first of all, these were government policy. It's aligned with government's priorities, and it was locally led. It was led by the government. And even the capacity development that was done in collaboration with government. So as a result of this work that we did, we had a set of trainers who have been trained to go around and train the rest of the country. And these are drawn from government agencies. So having government lead the way leveraging on already existing government institutions, government priorities, having laws that protect this policy will be very essential for sustainability. And then, of course, another very important bit of it is citizens' involvement, which, of course, we made sure that we enhanced in the way that we designed this program. So we had CSOs that have been trained to actually engage communities through town halls, and also established linkages between the CSOs and government agencies so that they could hold them accountable and also relay the citizens' voice and preferences to the government. So all these factors that were built into the design and into the structures that were strengthened would actually ensure that we have sustainability of these interventions. And that's already happening because many of these CSOs have actually included these things in their work plans. They are also picking up other policy that have been lying moribund and driving the reforms for this policy as a fallout effect of these capacities that have been built.
Thank you. Anto, the view from Indonesia.
Yeah, I couldn't agree more with Francis.
Yeah.
I think, the most effective way to sustain any project is to embed it with the planning and budgeting process of the government. That will ensure that the project will be carried on in a certain period of time. What is also important is that the indicators developed by the government may not be in line with the indicator that we would like to see from the project because they have their own key performance indicators. We also have our indicators. That's the challenge, I think, how to align the output that is want to be achieved together. And that what Francis refers to co-creation, design together, and then having a time where government and us as their counterpart listen to each other. I think that's the very key to sustain of the project, both at the central and at the local level.
Thank you. Emilia from
in
Guatemala.
In the same line, I really appreciate the opportunity that we have to work with government and civil society, because the civil society is the most sustainable resource that a country has. The functionaries change in our countries many times in the one administration, and every 4 years the whole administration, and the functionaries change, and again we need to start with the process. But the civil society is the main, for me, is the main resource that help the country in our work, help the country to put in place the policies and the unique, or in general, is the most interested side to demand the implementation of the policies.
Exactly.
And they continue and continue. They have a real interest because the necessities affect their life. Right. If I have the necessity, I will insist on the solution. Right. And this is the role of the civil society. This is the role of civil society.
That's also a great segue to the next panel, but I'm going to give David the last word. We've heard a lot about Kenya. What are your final thoughts?
Yeah, thank you, Janet. And I think since the government has spoken from Kenya, I don't want to add more, but I would like to address the question from our colleague who has asked about sustainability of their program using the agricultural output. I think we may need to discuss more so that we understand the financing landscape for health as a whole, because agriculture, as all of you know, has a lot of ups and downs. One year you get bumper harvest, another year you don't get any harvest, but the medical need is still there. So we need to understand the financing landscape so that we can be able to better advise. And that is when now HP Plus comes in to support evidence generation, because again, you can't work on just a short-term solution. There must be a longer-term solution, and that can only be provided if we have that analysis done to understand how is healthcare financing financed in your country, and so that we are able to provide proper guidance. And I think there's a lot of brain here. We can meet over lunch and try to brainstorm on how we can be able to support, because what the chief is doing is actually within his power, that is what the resources he has. Domestic resources he has there are the output from agriculture. But looking at it from a sustainability point of view, if agriculture doesn't do well, we need to understand how else are they able to finance healthcare in that country at that level, so that we are better placed to advise. Thank you very much.
Thank you, all of you. This has been such a rich discussion, and it's such an honor to be able to be here with all of you and be able to begin to share the lessons at this end of project moment, and hopefully carry those forward to the future for the important lessons that have been learned to help strengthen the response going forward, and to be working with all the partners on the ground, and hopefully really being able to improve health outcomes with a focus on policy, advocacy, financing, and governance. So please join me in thanking the panelists. Thank you, Janet. You guys were Okay. Thank you, and welcome to the next panel, which actually Armenia teed us off very well, because this is going to focus on the importance of civil society for localization in policy, advocacy, financing, and governance. And we have two amazing speakers on this panel who are bringing us perspectives from West Africa and from Malawi. So let me introduce them quickly. We have Modibo Maiga, who has more than 30 years of experience in the management, formulation, planning, and implementation of public health programs. He is currently the regional director of HP Plus in West Africa, where he coordinates the activities for HP Plus and advanced family planning in Francophone West Africa. And he has overseen many innovative initiatives to increase the involvement of non-governmental organizations and religious leaders in family planning and HIV in the region. Olive Mtema is the country director for HP Plus Malawi. She has over 20 years of experience in public health, sexual and reproductive health, and family planning. She has galvanized support among Malawi's policymakers for investments in family planning and population issues. And she has extensively mentored women in advocacy and leadership in family planning. She has a master's in public health from the University of Wales in Swansea and a bachelor's in nursing and midwifery from the University of Malawi. So to begin with, let me start with Modibo. Can you just give us an overview of why is it so important to engage and elevate civil society in order to advance localization in the region?
Thank you. Thank you, Janet. I would like, first of all, to thank you and to thank USAID for the excellent opportunity they gave us to work with civil society organizations. If we want really to go forward and to have a very inclusive participation of all actors, civil society should be there at the beginning, during the implementation process, and also during the monitoring process of what we are doing in the region. So I think working with the civil society also will help with what we call the democratization, the decentralization, and the demedicalization of the health systems. And this is very important to have them. And USAID started something which is really not new. They started in the 1990s, I remember, asking us to build a very strong network of civil society organizations who can work with the government, closely working with the government. And this happened. I remember when I started with very small organizations, civil society organizations, who became now very, very strong. And I can tell you when they were coming to my office, they were using bicycles. Some didn't even have bicycles. But now I can tell you, the one who remain, who are very sustainable, can even pay me, can pay my salary. They have very big buildings. And this is something we want to see. And it's important, their voices should be heard, because they are the only institutions who can talk openly to the government and make them accountable.
Exactly.
Thank you.
And Olive, you've also spoken about the importance of civil society for accountability, which is one of the stools necessary for to advance localization. Can you speak about what you see in Malawi as the important role of civil society in that process?
Oh, thank you, Janet. So we all know that governments, yes, are responsible for provision of social services. But we also know that most of the times, government may not be able to reach out to the needs of the population. So civil society are coming in to complement government's efforts. But also civil society participation would help to reach out to the masses. For example, in Malawi, we have Christian Health Association of Malawi, which has more than 30% reach of health services. So government partnering with civil society would enable to reach out to the rural communities where government cannot. And also participation of civil society organizations will help advance the services, yes, but also at the same time hold government accountable of its commitments, because they are like the eyes of government. They're always watching what government is doing. What have you promised? And then make sure that government live up to their promises.
Thank you. Since we're talking here broadly about policy, advocacy, financing, governance, sometimes it's harder to get your arms around what localization looks like in that domain and what is the role of civil society in that process. So I think it would be useful to look at an example of some of the impact of some of the programming. And Modibo, perhaps you could talk a little bit about your work with the CIPs, the costed implementation plans, and the engagement of youth, the engagement of religious leaders, so that the policy piece is actually advanced through the engagement of civil society.
Thank you, Janet, for this very important question. Civil society organization played a very important role in the formulation of on the CIPs, and also what was new and what we did, which is very new in the region, is really to know how to better engage private sector and also youth and adolescent. I think this is a new trend, and you can see now, thanks to all the support we are receiving from USAID, that youth are very vibrant in the region. So they participated, and they asked for money. And we had a big meeting with ministers of health, asking them to ensure that at least through the youth think tank of the Ouagadougou partnership that Sarah knows very well, we asked them to ensure that at least 15% of the total budget will be dedicated to youth and adolescents. And this is what we are doing now. You will see in all those CIPs that at least 20 or 30% in the case of Burkina Faso of the total amount is dedicated to youth and adolescents. We are not only asking for money, but we are making government accountable for all the engagement. You know, the commitment they took during the London summit, and also the commitment they took toward the Ouagadougou partnership movement. I think this is something which is new, which is going on, and civil society is always there during the meeting to ensure that things will move forward.
Exactly, one of the lessons of that whole CIP process that we saw a slide about as well. Olive, you've done a lot of work with engaging religious leaders on family planning messaging as a way of pushing forward the policy. Can you talk a little bit more about what you've done in Malawi on that score?
Okay. Thank you, Janet. So in relation to working with faith leaders to increase access towards family planning, messaging, but also encouraging Malawians to accept family planning, we have worked with the key religious leaders in the country. Evidence as we're implementing was showing that there were some messages that were, some messages that were still impeding access to family planning services. Although government was making more, advocating more for family planning, but also providing outreach towards family planning, but religious leaders' messages were impeding. So what we did was to leverage our existing relationship with the Ministry of Finance, Economic Planning and Development then, to work with the religious leaders, to engage civil society as well as the religious leaders. So what we did was to support the government to directly work with the religious leaders, because then there were not even, we didn't have any governance structures on how government can work with religious leaders. So we helped the minister to come up with a communication strategy and also guidelines to work with the religious leaders. So the work that we did was really to look at what was impeding, what messages, and work with government and religious leaders to come up with messages that would dispel those misconceptions or myths around family planning and religion. So the religious leaders themselves came up with the messages tailored to their faith. We had Christians and Muslims. So those messages, they had quotes from either the Quran or the Bible, trying to make sure that they are sending messages to the community that religion does not impede family planning. Religion even supports family planning. So that also really worked well, and they integrated those messages in their routine sermons. As we are talking now, they have the guidelines, and those things are institutionalized in their sermons, in their teachings, and they are part of the process. So religious leaders don't ask people to come to church or come to the mosque. So it means that continuously they're reaching out to the Malawians with the messages. So now we see that family planning is no longer a sensitive issue in the country, because religious leaders are really, people believe in them, people listen to them. So integrating in religious leaders has really helped to advance family planning agenda. Yeah.
It's also interesting to see how in both of your country works, you have integrated the work with civil society into domestic resource mobilization for these issues. Certainly, Olive, maybe you can talk to us a minute about the how you've engaged members of parliament as well as the government on the FP 2020 commitments. And similarly in West Africa, Modibo, you have lots of experience on that. How does engaging civil society impact domestic resource mobilization for these PAFG issues? Modibo, give us an example from your work.
Thank you. Before that, I would like to stress the point that we did amazing work with civil society organization, also in the area of HIV, so giving them small grant. And now it's USAID West Africa who is giving them direct small grant based on what we have done with them. So we are capable to do all the work we are doing now, and we shifted our work to give them more support than implementing directly the programs. So I think we have a very nice example of civil society organization advocating for resource mobilization. And I can highlight the case of Niger, where we work with what they call the WAHO champions. And they spoke with the president of the parliament, the prime minister, and also the minister of finance and the minister of health. And this is where we got to move the budget, the national budget dedicated for family planning in Niger, to 62 million to 200 million. This is something they did with a little support from us. We just trained them on how to do the advocacy, and they conducted all those things by themselves. And they only, after that, they also make the government accountable. I remember during one meeting, they asked them, how did you spend this money? We want to know. And this is something very important.
Absolutely. And maybe you can give us, Olive, a little bit of a sense of what you have done to move that forward in Malawi.
Okay, thank you. So for Malawi, the issue was how would we have government show their political will towards family planning? So our entry point was FP 2020. So we had worked with the civil society organizations and the stakeholders to include the creation of budget line in the commitment of the government. So for us to move forward, we had to work with the people that would approve like national budgets. So we went through the members of parliament. We had to build their capacity in family planning and reproductive health for them to understand the plight of women. So we took them to the field for them to understand, and then work with other civil society organizations to push so that we can have a strong voice, like women leaders, the youth, and even other stakeholders in the society. So the issue was with the members of parliament, they agreed that they are no longer going to pass the then budget in 2013 if family planning is not included. So they had built their own coalition within the committees of parliament. So came 2013, they refused to pass the budget without family planning included. So what happened was that parliament agreed to pass the budget with a family planning budget included, but it was a zero budget. So we also went back to the drawing board, work with other civil society, the civil society organizations, to raise the voice, even the media, to push government, Ministry of Finance, to put family planning resources. So we have seen that the work that we've been doing, the family planning budget has steadily increased. And during HP+, we have just been there to provide the evidence, the support that civil society would need, but they kept on pushing government to put in more resources. As we're talking now, the budget has increased by 138%, it's about 470 million kwacha. So it's something, so the capacity that we've built with civil society is still pushing. It has become like sustainable in them to push for family planning resources. Thank you.
Thank you. As much as there's so much to be excited about and build upon and some good news, really, there's also huge challenges. And I think we can't underestimate the ongoing issues that civil society is facing in the regions, and also the support that can be provided in new and hopefully catalytic ways. So Modibo, can you talk a little bit about what are some of the key challenges and what you see as the way ahead?
Excellent. I think the first thing is to understand that as civil society, when we talk about them, it's multiple actors. First thing is to know them very well, to have a good mapping of civil society organization. There are some who are very big, some are very small, and how to work with them, and how to ensure that you trust them. I think this is the main thing to do, to trust them first, to give them confidence, and to let them do the job. So we need to find a way where we can give them room to work closely with the government. I think this is a big challenge. Very often, government is just sitting alone, and civil society organizations are not very well involved. And our dream is to have them doing everything together. And at the end of the day, to have also contract coming from the government. It's called in French contractualization. To give them contract from the government money because it's their country. So what we are doing, how we can sustain it. It's a project for 5 years, 10 years will go, but the government will stay. And how we can help the government to understand, to advocate that they should also use their own civil society organization to do the work that they can do alone. I think this is very important. And also, we need to help them to bring the silos among them, how they can leverage from each other, work closely among them, and having one voice to talk to the government.
Thank you. Olive, I know there are a lot of challenges as well in Malawi. Can you speak to some of the challenges you see and what you see as the way forward?
Thank you. So to build on what Modibo said, the coordination, like the civil society organization coordinating to have one voice, but also in our case on family planning budget, it was one thing to advocate for the resources, but then we also saw that there was a challenge by government to actually spend the resources towards the family planning. So there was a challenge on tracking the expenditure. So continuous holding government accountable of the commitments was also a challenge. And also in terms of family planning, domestic resources, another big challenge was the commodities, because government had no motivation to put in resources for family planning because they already had donor-funded commodities. So the availability of the donor-funded commodities made them not having the will to put in more resources towards family planning. That was the main challenges that I see in the budget advocacy week.
Thank you, thank you. We are fortunate to be joined by Seydou Traoré from Mali, and we'd like to welcome him from the floor to give us a bit of perspective of your country team in Malawi and what you see as the role of civil society in advancing localization.
Merci Janet, merci. Bonjour tout le monde. Ce que je voudrais dire à la suite de ce que le Malawi, Modibo et tous les intervenants ont dit, c'est que le partenariat HE+ a joué un rôle important dans le partenariat entre les OSC et le gouvernement dans la planification, dans l'élaboration, la mise en œuvre, le suivi du plan national de plan national contre la pour l'APF.
Thank you for the opportunity to share. And following up on what Modibo said, HP Plus has played a strong role in strengthening partnerships for implementation, monitoring of our costed implementation plan for family planning in Mali.
Cela est d'autant plus important que ce partenariat avec les organisations de la société civile, au Mali par exemple, dans notre cas où nous avons beaucoup impliqué les associations et les réseaux de leaders religieux, permet de pérenniser les activités et de faire en sorte que le gouvernement soit redevable des résultats à venir. Maintenant,
So this strong partnership that HP Plus has been able to build with civil society organizations, and especially with the network of religious leaders in Mali who are extremely influential, contributes to the sustainability of the results that the CIP is achieving in family planning.
Maintenant, nous avons beaucoup d'exemples par rapport à l'opportunité et à la nécessité d'avoir ce partenariat. Et maintenant, la question que je pose, qu'est-ce qu'il faut faire maintenant pour que nous puissions nous assurer que cette pérennité, que ce partenariat entre le gouvernement et les OSC puisse être pérenn?
So now the question is, considering how important and essential this partnership is between the government and civil society, how do we work to ensure the sustainability of partnerships between government and civil society? So we ask that to you.
Thank you. And I want to give our panelists time to answer. Do we have time for one more question from the audience? No. Okay, sorry. The official timekeeper has told us no. So let me turn it back then to Modibo and Olive to respond to these questions again, and any last thoughts that you'd like to say about next steps and the way forward.
Oh, thank you. This is, Seydou, a very important question, and I think the answer is two things. The first thing is to demonstrate the value added by the civil society organizations. This is very important because very often government don't trust them very well. They don't see the value added. They don't document the result. They don't give a proof that they have done very successful job. This should be done. And as I mentioned, they should have a good coordination, one voice to talk to the government. As you know, this is what we did in the Mali in the 1990s. A very strong and powerful network for more than 200 civil society organizations. And we are also organizing, at this time, we are organizing a meeting with the Minister of Health every year. He's visiting one of the NGOs on the field to talk with, NGOs. The US ambassador was there, everywhere, the donors, and they can hear the voices of civil society organizations. I think this is very important. It's also important to talk with donors, and this is a catalyst role we think that USAID can play also with other donors, to ensure that the government will also use their own money to leverage from what USAID is doing with civil society organization. If not, it will not sustain. So we can do some programs for 10 years, 20 years, but it will collapse later. And what we did also in some places is to convince the government to give money to the civil society organization directly. They did it, but what they did, they took the money from donors, they took the money from the World Bank, and this was not sustained. Now the advocacy should continue to ensure that the money will come directly from their own money, the national budget.
Thank you.
Work with them.
Thank you. I'll have just 2 seconds for last words, way forward, any response to your colleague from Mali.
So I think way forward from what we've seen, the important role that civil society are playing, there is need to engage them to be part of the agenda setting and implementation. Because we're seeing that, for example, in Malawi, civil society action is coming as an afterthought. So we need civil society to really, as Modibo said, include resources in their budget so that they are able to effectively advocate and hold government accountable. And also look at other ways of mobilizing resources, not only from donors, but other funders like the private sector. Thank you.
Thank you. Please join me in thanking this panel.
Thank you, Janet.
Thank you.
Yeah, he'll mic you. Thank you so much, Janet. Thank you. Just have a seat in line behind Jay. In line behind Jay. Just have a seat in line behind Jay, yeah. And my seat. No, seriously, that registration is huge. Thank you. I appreciate it.
Look at the light. All right, I think we're ready to start. Hi, everybody. I'm Jay Gribble. I'm Deputy Director for Family Planning and Reproductive Health of the Health Policy Project. We've just heard about localization experiences from the perspectives of HP Plus country directors, highlighting the project's works in policy advocacy, financing, and governance, and a wide variety of ways that each country is working to advance local ownership. With this panel, we hear a complementary perspective to localization based on the experiences of 4 individuals who work with USAID and bring significant experiences working in USAID missions. With me today are Mohammed Nasir Wazam. Nasir. He's a senior community-based family planning technical advisor in the service delivery division of the Office of Population and Reproductive Health, where he also represents the division or the office on USAID's Global Health Locally Led Development Working Group. Previously, he served in USAID missions in Bangladesh, Rwanda, and Nepal. Our second USAID representative is Premila Bartlett, a senior reproductive health and family planning advisor in the Office of Population and Reproductive Health.
She previously served as a health officer at USAID missions in Malawi and Ethiopia. Our third person will be Sidi Cisse, a health economist who serves as a health and policy advisor at the Mali mission, where he's activity manager for Health Policy Plus. His specialty is health system strengthening, including health financing and governance. He was previously at the Ministry of Health in Mali. And our fourth person is Irene Ngenda Kumana, who's a physician and public health specialist. At USAID in Burkina Faso, she's a program management specialist for the PMI program and is also a supply chain, community health, and vaccination point of contact. We're happy to have here today as her role as HP Plus activity manager in the Burkina Faso mission. So thank you all very much for joining us. Their perspectives are broad, reflecting experiences in a diverse group of missions in countries that are at different stages along the development continuum. One thing we know from a policy project over many years is that policy implementation is not a linear process, and it certainly doesn't look the same in every context. So let me kick off by asking Nasir about his experience as in missions, as well as working in USAID Washington for a few years. What are your thoughts on the time frame for movement toward localization? Nasir.
Thank you, Jay. Thank you for your introduction and asking that question, the time frame. I think that is the most embarrassing question. I mean, giving the answer, giving any number, nobody will agree with me. Okay, it is a 5 years, 6 years, 7 years, whatever the number. Meaning that we cannot tell you any number. It's a process, and it is a very context-driven process. As you mentioned, Jay, it's a linear process, and different countries, different organizations are in different continuum of development. So you cannot, it's very difficult to generalize, very difficult to give you a time frame. So when you're working in a X country, say for example in Malawi, or in one organization in Niger, that will not match with Bangladesh government or any organization in Bangladesh. So it's a very, very context specific, context driven, which organization you are talking about, which organization you are working with, or which countries you are working with. Let me tell you what is the purpose of USAID's development work. That is a sustainable development. It was not development, we are talking about sustainable development. And over the years we have learned, and we thought this sustainable the cornerstone of sustainable development is a capacity building. And now we are talking about, okay, capacity building for whom? For sustainable development, which will be sustained. So that is the local organizations. If it is a locally lead organizations, if it is a capacity building of the local organizations, so that will sustain. So we are talking about our lessons working over the time, the general development, we are going with the money, we are going with a consultant, giving them a money, giving them some thoughts from our Western perspective. That helps, but will that sustain? Our question is, okay, we have learned it may not be sustainable development. So we are thinking about, okay, if we can grow local organizations which will be locally lead and we can develop their capacity, that will, but it's a long process.
It is a long process, and I hate to cut you off, but we've got a lot of short time and a lot of content to cover. So if you can sum it up.
I just, it's a long process, and the most important thing is a soft skill development process. It is, so soft skill development is a time-taking process. I can give example from Bangladesh, the social marketing company. That project was, USAID funded project was started mid-70s, and it was a USAID-funded small project. Now, over the period, it became a very sustainable organization. It's a classic example of USAID-funded projects, but it took 2.5 decades. And now their budget is $100 million. So there are so many examples from different countries. So it is a context-driven, and there is no time frame, but there is a time frame for development process.
Okay.
Thank you so much.
Thank you, Nasir.
Sorry for taking time.
Pramila, you've worked in a lot of different missions, dealing with different policy actors. From your perspective, in these experiences, a lot of different contexts, what does rolling out a localization policy mean where capacity may be stronger or weaker, or a country that has more resources or fewer resources?
So, thank you, Jay. So essentially, with respect to the whole localization agenda that USAID is now moving forward with, there are three essential components: locally led development, strengthening local systems, and local capacity development. So within that context, I will talk about capacity development. Or rather, three things: capacity development, resource mobilization, or domestic resource mobilization, and strengthening of local systems. And with respect to weaker countries, or weaker countries with weaker capacities, it's not always going to be very easy. It's like, for instance, Kenya and South Africa have a big pool of skilled and educated people, whereas other countries, smaller countries that have limited resources will find it more difficult. So given that, we have to also be cognizant of the question, how can we build capacity when there's nobody to build the capacity of? Because to give you an example of Malawi, and actually I was the activity manager of HP Plus there when I was there, the Reproductive Health Directorate was initially a unit under the Clinical Services Division in the Ministry of Health. And with the FP 2020 commitment, it was essentially moved into a directorate status. But the systems were not set up for it to be an autonomous directorate. So as a result, the staff were actually under the purview of the central hospital. And HP Plus was supporting the capacity development of the individuals working in the RHD. But when they were promoted, they were moved to the central hospital, leaving nobody there for them to develop the capacity of. So that was a huge challenge. And so within that context, what HP Plus did was advocacy, and put into place the systems and the processes to make sure that the staff were allocated properly to the directorate. So we are going to have all these issues with countries that have weaker systems, weaker capacity. Then with respect to domestic mobilization, the question is, what does it mean if a country doesn't have adequate domestic resources to mobilize? So within that context, we have to do what we can. Olive talked about the budget line item that was put in. Advocacy efforts were made, and so that was done. It's still a small amount of money compared to what the development partners are putting in. But still, it's something. It's the beginning, and that's how things are going to grow.
Pramila, I hate to cut you off, but we are almost out of time. So.
Okay. And then there's also the whole system strengthening aspect of it. And unfortunately, I can't really talk about all the things that I want to talk about.
Challenge, yeah. Okay. Thank you, though, so much. Sidi, Mali is a big country, dispersed population, decentralized, making policy, advocacy, finance, governance, policy dialogue challenging. Given these types of challenges, what are your thoughts on how to implement the localization policy in Mali?
Okay, thanks for the very interesting question. And Mali has more than 400 primary health centers run by locally elected associations. And since the country is really very vast, as you mentioned, almost more than 40% of the population is located more than 5 kilometers within a radius of health center. And this explains the importance of localization, which has taken the advantage of many strategies, including the transfer of skill to community health workers. So having been more equipped, the community health workers are able to provide life-saving services and also address the problem of geographical accessibility. So again, kudos to the community health workers who provide life-saving and promotional services. I mean preventive health care that is much more efficient in the first place. With the support of Health Policy Plus, USAID has done extensive work to institutionalize the approximately 3,000 community health workers in Mali. And some milestones have been achieved. So I was pleased this morning it was acknowledged that the Council Minister has passed a decree last week that has provided the legal framework to pay monthly stipend to the community health worker. So we are not at the end of the road because we need also to work with the Ministry of Finance so they could make some provision to pay for the stipend, and also we will work with the beneficiary so we could find like a local solution in between. Over.
Thank you, CD. So you're not at the end of the road, but you're at the start of a new one. So this is a great opportunity. Irene, how would you deal with the situation where USAID's localization agenda really doesn't align with the country's agenda, such as maybe the role of civil society in governance or inclusion of underserved populations, these types of things? How is USAID going to deal with that, or how will you deal with it? Because it's bound to happen.
Yes, thank you so much. So thank you for the introduction and thank you for this question. I think that in Burkina Faso we face this kind of situation. I will not say several times, but we have to deal with this situation. What we've done is to make sure that we keep talking with the government. Sometimes they're bringing some very, very valid points, so we need to listen to them, and this is very important. The second thing is that when they're bringing some valid point, then we can address them by showcasing what the other countries or other implementing partners are doing. We're not reinventing the wheel. We're sharing the evidence. We're showcasing what other countries have done. And we're making sure that we can bring the right people at the table so that they are informed. And the last thing, and this is very interesting, in Burkina Faso, our mission is not that big. It's a very small mission with a growing health portfolio. We have over 20 mechanisms working with us. And we realize that this is a strength. So HP Plus is working with us to make sure that we have monthly meeting and quarterly meeting with all the IP supported by the Burkina Faso mission. So in this place, this is a safe place to discuss any sensitive point, to define a strategy, and to make sure that we're speaking with the same voice in front of the government. This is really useful. Well, we don't underestimate the power of this networking and this, IPs together, coordinated by HP Plus. I want really to thank them for the work they're doing. And this is really helpful to address this kind of situation.
Wonderful. Thank you, Irene. So I know we're out of time, but everybody is, we were out of time before we started. But one of the things we do a lot is the elevator speech, the opportunity where you have that person you want to influence for 15 seconds. So I'm going to ask our panelists, 15 seconds. What are the opportunities that the localization policy from USAID brings to countries? Nazir.
I mean, the realization that the locally led development only can be sustained. So that realization creates the great opportunities.
Wow. Short ride, powerful message.
What if I say
Premila.
ditto? And I'll cut, and that way I'll
take
cut
what he
that.
had, yeah.
Yeah, go ahead.
Yeah, the work we should have been doing with the beneficiary has to be data-driven, so they could see and understand the result, which is in itself a kind of advocacy. Over.
Thank you. Wow. And Irene.
I will try.
Okay.
So we're working with the youth and adolescents. They're very committed in Burkina Faso. We're facing a lot of governance issues, and we think that breeding and working with them will bring a better future for this country.
Wow. Powerful. Excellent. So we've got a few minutes for question and answer. We have a captive audience, USAID mission and Washington staff. Any quick questions?
Can I just say
Sure.
something?
Yes.
If you want real success, you need to make sure that the people who the programs are going to benefit really own it and work to actually achieve the vision that they have. And otherwise it's not going to be sustainable, which is what Nazir was talking about. There has to be a vision, there has to be buy-in, there needs to be passion, and there needs to be the energy to make that vision come to life. Over.
Premila, you had me holding that open door button while you were talking, so excellent comments. A question or two from the audience. Oh my gosh, this is hard to believe. A group, okay.
So I was actually going to ask this just as a general theme, but given our esteemed panel of USAID representatives, one of our issues, as you know, are many of these projects are externally funded. So with like from the Global Fund or from governments outside of the country that's targeted. So as we talk about localization, and I'm hearing a lot of insistence on governments taking responsibility and then cascading that to the local communities and civil society. But what do you do when you have all these donor streams, meaning from the Global Fund, from PEPFAR, from family planning funding streams, from other governments? How would you advocate for localization, given you have all these competing donor streams, possibly even from outside of the country?
Yeah.
So it depends on the government and really their modus operandi. So if for instance, when I worked in Ethiopia, it was very much government driven. They had the vision, they went for it. And in fact, the vision that they had, it was Dr. Tedros and Dr. Kasete. They were going to have 10,000 health extension workers deployed. And the development partners basically laughed them out of the room. But they said, but the thing is that within that time frame, they didn't have 10,000 health extension workers deployed. They had 30,000 health extension workers deployed. So it depends on the government and how they work. And if they are strong, they will tell the development partners, this is our vision, and this is how we plan to get there. And if you want to work with us, please do. If you don't want to work with us, that's fine. So there's that aspect of the way that governments work. There are other governments that would say, okay, they listen to everybody, and sometimes they're successful in getting to their end vision. Sometimes they're not because they're a bit confused. So I think it depends on the governments and how they actually work with the powers, the other external powers that come in. Over.
Thanks, Premila. CD and Irene, I see you jotting down some thoughts. Do you want to share them quickly?
Yeah, maybe I will start. I think what also is important is just to work together, because like if you just add them up, you will find like very important resources. So we have to make sure they are very efficiently used, and we have also to communicate like among donors to improve like governance and prevent some misuse of those funds. So, and sometimes I just want to acknowledge, like in Mali, we have done a study with Health Policy Plus, just like to see how we can better use resources available, just like to take into account performance. And then when we have a recommendation, we work all together, having like a clear mapping of who is doing what in each region. So that will help also talking together, having regular meeting, so we could improve together the outcome of our health program.
Thanks, Sidi. Irene.
Yes, two things very quickly. So working with civil society to make sure that we empower them so they can make the right choice. They're sitting at the decision table now so that they can request what they want. Without our support, they can do that. The second thing is that to make all the partners accountable. So we supported the government to develop the one plan, one budget, one report strategy for the next 10 years. And with this strategy, we're sure that all the partners are supporting the same thing. We are going in the same direction. This is a permanent discussion. And when we're working with a global fund, you have the CCM, the country coordination mechanism, which is a nice place to also continue to discuss with them and try to have the same, to go to the same direction.
Thank you. So Irene, Sidi, Premala, Nasir, I apologize for my heavy-handed tactics in cutting you off. We've had such little time, but...
I just wanted to add one thing.
Okay, one final thing.
This is very frustrating because I have so much to say and so little time. But from an operational standpoint, there's also the health donor group coordination mechanisms that exist within countries. So that is one way that everybody can be brought in to kind of coordinate activities to support the government's visions. So I'll leave it at that.
That's a terrific point and a good one to end on, with coordination through donors, with donors, and with country decision makers. Thank you all so much for participating today. I know it's been challenging, but I hope that your contributions across the different country experiences continue to advance localization within USAID, within health, within PAFG. So again, thanks so much, and look forward to seeing you during the rest of the day. Thank you, everyone.
Thank you, Jay. Thank you for audience.
Thank you very much, Jay, for leading that excellent discussion. And thank you so much, Pramila, Nasir, Sidi, and Irene, for those excellent leadership insights and the comments that you made, which are very useful coming from the donor's perspective. Now, of course, within the past 2 years, we've had a very tiny, minuscule virus bring the world to its knees. And that is the next session we're going to talk about right now is going to reflect on the role that the USAID-funded Health Policy Plus projects played in the COVID-19 response and recovery achievements, with a special focus on our experiences from Central America. And with us today to start that discussion is the Health Policy Plus Deputy Director for HIV and COVID-19, Sarah Bowski. Over to you, Sarah.
So thank you, everybody. Thank you for allowing time for this session. You know, having worked in HIV for nearly 30 years, we talked about there being a pandemic, but I don't think any of us expected it to be what it's been today. So, you know, we have a tradition in the United States, and there are many traditions that started throughout the world. Sorry, I get very emotional with this team. So we have these traditions that we do, right? When healthcare workers change, shift. What do we do here? We clap. So I'm going to ask my colleagues, my esteemed clinical staff, please rise, and could we please applaud them onto the stage? So these men and women and some of our other staff work tirelessly, not just for HP Plus in their countries, performing surgeries, putting people on ventilators, taking them off, informing families, and watching people recover. So thank you. First, I'd like to introduce our staff as we all get organized and we try to cram a lot into a little time. They'll be here for questions and answers. First, I'd like to introduce on the far left, we have Dr. Flores, who is our country director in El Salvador, and he's also our regional technical director for all 3 countries that you'll hear about today, Honduras, El Salvador, and Guatemala. Next to him, we have Dr. Tesoro, who is a senior advisor for the HEP+. They correct me all the time. And he is our COVID everything. And then we have, there's a lot of COVID people behind them, let me be clear, but in terms of this today. And then here we have Dr. Serrato on the far left. She is our deputy director from Honduras. And then we have also with us Dr. Rivera, Sarah Rivera, who is our, who is a technical advisor, and she specializes in case management and infection and prevention control. First slide. So I'd like to dedicate, obviously, this presentation to all frontline workers and what I call our second line workers, many of whom are in the audience today: David, Madison, Deanna, Ashley, others, PMU, you all know who you are. So as we begin, you know, HP Plus globally, right? There's a lot that had to happen quickly. So we had to adapt our business and implementation strategies to the new reality imposed by COVID. And when I say that, I don't just mean in terms of policy advocacy, finance, and governance. We had to adapt quickly and globally how to protect our staff, take care of our staff. And we had to come up with a new way of doing work in this new environment as fast as we could. And I really believe that HP Plus and Palladium globally, and as a project with USAID, was at the forefront of that, called on often by other IPs and governments. I just got a minute thing. I didn't know you were there. So enablers for success. So I think the most important thing, and this covers across all of HP Plus, is that we are a trusted partner. The people you see on this stage are from their own country. They grew up there, they went to university, they work within the government, with USAID, and we are trusted because of our local staff in these countries. And having a platform of trust was essential in COVID, because we didn't have time to pick and choose. We didn't have time to sort of build and nurture these relationships that we do for years and years. And so with that, I would say that that trust was also with civil society, multilateral, and it was quick, it was fast, but there was a foundation. And there was also our reputation as HP Plus throughout the world. Equally, enhanced collaboration, learning, and adaptation. Adaptation, I hear Farley every day. If you're doing a vaccine plan, make sure it's adaptable, Sarah. Every single thing has to be adaptable and fast. And that's what we did. But we also had to adapt, for instance, when our staff got sick. We had staff who were very sick. We had to flip in, flip out. Dr. Serrato providing care to staff members in Honduras. We also had natural disaster, right? We had a hurricane 3 months in to the pandemic. There was a hurricane that slammed all 3 of these countries. So we had to quickly mobilize to figure out how do you take care of 2,000 people in a shelter and try and prevent COVID when there's no vaccine, and we really didn't know much about prevention. So adaptability, no problem. That said, we also have local solutions, and we've heard a lot about that, so I'm not even going to go into local solutions, because you're going to hear a lot about how did we take international policy that was being built as everybody was running as fast as they could, and how did these people stay steadfast and grounded and take those policies that we weren't even clear about here, try to figure some of those out, right? The calculator just came out yesterday to figure out your quarantine, but they were able to take those quickly, adapt them, and feed theirs up internationally. So we've found multiple ways to address ongoing challenges, specifically in how do you develop a policy and rapidly implement a policy. Next slide. So this slide represents the blue dots are all the areas that HP Plus has worked. So in COVID, you'll see some of the traditional areas such as modeling in Burkina Faso, the top, strengthening lab capacity, surveillance, case management, infection prevention control. Those are all the WHO pillars. The other thing important to notice about this slide is that while these are all the HP Plus dots, I can tell you that from this work, right, as HP Plus has hit the ceiling, we've also been asked, these same staff are continuing much of this work both as a sub-partner to EPIC, the FHI EPIC project that we're on. Datafy has come in, and the same staff, so we have continuity, right? Really essential, as we know in clinical work. Continuum of care and policy. Next slide, please. This slide was taken early in the pandemic, and this represents now we're moving into 3 countries, which we're going to profile today. This was taken in Honduras, and this is a photograph from a donning and doffing of PPE, not an easy feat. They can tell you all about it at break. Next slide. So the major milestones this year, this month, 2 years ago, WHO declared a COVID pandemic a global lockdown. We all went into some kind of lockdown 2 years ago this month. And then we moved into very, very quickly, probably in my 30 years working both at AID and for international partners, the fastest, most effective work plans I have ever seen. It was turn it around in 2 weeks and save everybody. But they did it. We did it. We had a well-oiled machine in headquarters and incredible staff on the ground. We had no staff in Honduras at the time. We now have a full, and USAID didn't even have a health office. Today, very close friends, USAID, our USAID partners, Charles Oliver, Ima in Guatemala, we have David Castellanos, they're all on speed dial with our staff. And it's a beautiful relationship, and it's been incredible. So through this, we continued in laboratory capacity. We moved quickly into El Salvador doing ventilator work. And then as we moved forward and vaccines came out, guess what? Yep, we got involved in vaccine work, and that's what we're doing today. And you'll hear a lot about that as I quickly step off of this stage and now introduce you to Dr. Cerrato from Honduras, who's going to speak a little bit about what's been done in the 3 countries overarching, and then you'll get a little deeper dive into each country, followed by, hopefully, Q&A.
Thank you very much, Sarah. Good morning. Please get prepared. Fasten your seatbelts. We are taking you through a quick journey over the Northern Central American countries. Next slide, please. So we will start very rapidly with a crucial and key element for all technical assistance around the world. And I just want to give a quick introduction. Like, naturally, when we think about engaging and bringing impactful outcomes in our personal life, we all want them quickly. Isn't that right? But I think that whenever you think about impactful outcomes, if you want them to be quicker, then you cannot do it alone. So that was very important on the first hand for HP Plus project. And I want to highlight that amidst an emergency response, HP Plus supported and it identified at the very beginning how crucial it was to build strong relationships and engage with other diverse stakeholders to move and then says quicker and harvest better outcomes in a short period of time. We built very fluent communication and empowerment of the government commissions, but we not only try to engage the public sector, but also we work with the different multi-sectorial committees, also engaging international organizations such as the ones that you are seeing now on the screen. And we also build this, not only the fluent communication, but we started building relationship with all of these stakeholders in country. And HP Plus served as the liaison for other USAID implementing partners in the 3 countries. Next slide. One of the first actions that HP Plus did was assessing the US government donation of mechanical ventilators. By that moment, there was a huge surge of critical and severe COVID cases that were outbursting in the 3 countries, and our critical care areas, were collapsed by that moment. So the US government sent, and we helped distribute 210 ventilators in Honduras, 50 in Guatemala, and 580 in El Salvador. After that, we performed, next slide please, facility level assessment, which helped us identify which were these prioritized hospitals in which the ventilators were most needed. And we helped them distribute them nationwide on the 3 countries as well. Something impactful was that from this assessment, we not only identified the need of the requirement of the distribution of the mechanical ventilators, but we also used this tool to identify major gaps and opportunities and challenges that the countries were facing. And the impactful numbers were that we identified that less than 1% of the nurses in the countries were actually, they actually had the competencies on critical care. And another impactful number was more than 70% of the frontline healthcare workers at that moment were very young general practitioners who just came out from the university, from med school, and didn't have any idea of how to manage a severe case. So that was, it was impactful for us to know that 70% of the people who were actually attending a critical care patient didn't knew how to, start on a mechanical ventilator. So that was really critical, and we identified that with this assessment, our top priority was to build capacity within our frontline healthcare workers. Next slide, please. So one of the first things that we started doing from the basics was to identify how we can keep these healthcare workers and young practitioners alive, first of all. As at the same moment that we were having a huge surge of critical care and severe cases that were going into the critical areas, we also had high rates of healthcare workers infection. So we started with the IPC, which is the infection prevention control part of it, and we delivered through HP Plus PPE sets for practice use so that they can actually start doing the recommendations on hand hygiene, how to correctly use a and wear a mask, and also the PPE donning and doffing. The doffing was the critical part because most of them were, have been infected during this part of the procedure. So at the same time, we developed a tool that it was like competency-based checklist. So we partnered them with someone else who can actually observe how they will be doing the process, and they actually, go step by step, checking how they were performing the procedure. So in that scenario, our main goal was to train them in how to, do the IPC recommendations correctly. And also, something critical was that not only in-person sessions were delivered, but we wanted to train nationwide. So our local team on the field record themselves and post videos in the HP Plus YouTube channel that were distributed among the 3 countries. Next slide, please. Simultaneously, the ventilators were installed and distributed. We also built a curriculum development to strengthen capacities in these frontline healthcare workers. So not only an IPC, but more than 5,000 frontline healthcare workers also were trained on the COVID-19 case management, oxygen therapy, mechanical ventilation, and other aspects of the acute respiratory distress syndrome and evidence-based recommendations so that they can, have the capacity to attend critical care patients by that time. Next slide. As mentioned before, and grounded in its mandate to support policy development and promote the sustainability of investments, HP Plus supported also the Ministers of Health in Central America to develop the following guidelines that you are now seeing on your screen. I will just mention them really fast. We have an IPC recommendation, which is a practical guide for IPC. We have the administration of the COVID-19 vaccine and management of adverse events. Our latest document, it's at the bottom of the left side, which is a long-haul COVID document that is now under review, and that will be implemented on the 3 countries. And now I will speak a little bit of our top and most popular document that you may have heard before of this. This was the COVID-19 home-based care quality practical guide. This was a guide that originally it was written in Spanish and then translated to English, and several countries have been using this guide. They have adopted it and use it as a policy document in several countries. This guide was intended for frontline healthcare workers and trained them on how to provide quality of care at the home center. By that moment, as I mentioned before, we had a high increase of volume of severe cases that had our facilities collapsing because of the outbursts of these cases. So it was important to teach our frontline healthcare workers how to identify the case and also provide practical recommendations so that the family could perform attendance or management of the COVID for mild cases. So it is worth noting, next slide, that the product that we developed were developed in one country and were implemented in several others. But not only is the release of the document that matters, but also to provide training on the same document to frontline healthcare workers and other persons. So that now in this slide, you will see that overall in the 3 countries, more than 7,000 healthcare workers were trained. We have a nationwide impact with coverage of 100% of the health regions in the 3 countries. And in the bottom, you can see the total downloads in English for this document and in Spanish. So together we have more than 23,000 downloads, and these are not counting the download from the Open Critical Care, which is a page from, the UCSF. So I think that if we get now today the downloads, this is a high volume and high demand document that are still being downloaded, not only by frontline healthcare workers, but also by general population that is very interested in learning how to manage a family member in the house. Now, I will hand it over to my colleague Sara Rivera, who will start diving deeper on specific activities, and we are going to start taking you to this traveling to Honduras now. Thank you very much.
Good morning. I will talk about Honduras now. You're in Honduras in Central America, and I will take you, I will start by providing a brief overview of my country. We are a country of 9.5 million people, of which 9% approximately self-identify from a member from an indigenous community. 5% are over 64 years. You can see in the graph here that we've had since last week, we have more than 400,000 cases of COVID-19 and more than 10,000 deaths reported in the country. However, vaccination has speed up. It began in spring 2021, and at least 82% of the population has 1 dose of COVID-19 vaccine. So, and 2 doses, 71%, and it's rising every day. So now, can we move to the next slide? Please allow me to give you more detail of the main activities in Honduras. I'm not gonna read all of this. These are the main activities in Honduras in this milestone graph. But in March 2020, the first case of COVID-19 was reported in Honduras, and the country went into a state of alert, mostly preparing hospitals to receive patients. And thinking about ensuring sustainability, we joined forces with the Intensive Care Association to provide training to healthcare workers through a training and mentoring program. We also participated in the distribution and training of healthcare workers in donning and doffing of PPE, as Dr. Cerrato mentioned, in all regions of Honduras. Shortly after that, cases of healthcare workers infected with SARS-CoV-2 were rising in the country. So the project supported the Ministry of Health in the development of 2 guides. One was the Infection Prevention and Control Guide for healthcare workers, in which they could see like a quick document where they could find recommendations on how to reduce the risk of infection and protect these very important frontline healthcare workers. The other important guide was the home-based care guide. So a lot of attention was given to the management of patients with severe COVID-19, but the amount of efforts being done in the community were less, and you could see that at the moment. So the home-based care guide provided healthcare workers in the community the tools to educate patients and family on how to manage their COVID-19 at home. Also, the HP Plus has been providing technical assistance on vaccination at the national level in the Ministry of Health office, and also has been part of the strategic advisory group for vaccination, and also has been leading the donor investment mapping in Honduras. So, next slide, please. Now I would like to talk to you a little bit about how we have been supporting laboratory capacity. With technical assistance from HP Plus partner RTI, specifically from Quare Quiner, the project has helped the Ministry of Health to process a backlog of up to 40,000 samples to identify SARS-CoV-2. We have also contributed to building capacity on best practice in quality improvement in laboratories, and also supported the opening of 3 new laboratories in the country. Also introduced the multiplex technology TAC path for processing, sample processing at regional level, regional laboratories. Also, TA has been provided to improve the workflow of 3 regional laboratories and also the National Virology Laboratory. Moving to the next slide, a little bit about case management. Okay, so coming back to the critical care training that I was mentioning earlier, after the facility level assessment that we conducted in 21 out of the 32 hospitals in Honduras, we joined, as I mentioned, we joined forces with a medical association, and we provided training to healthcare workers in 10 priority topics, mostly focused on the management of severe cases of COVID-19. At the time when the pandemic came into Honduras, there were only 16 intensive care specialists in the country. So most of these patients were going to be managed by general doctors and nurses with no training at all in intensive care. So how did we train people in other regions where they didn't have an intensive care specialist? So the mentoring program and the training program that you will see in the next slide provided training to these healthcare workers in all of these topics that you see on this slide. In the mentoring program, more than 70 healthcare workers in different regions were receiving mentoring from an intensive care. They had the intensive care to resolve doubts and just manage patients in all the regions. And also the training program that you see that we had in 25 out of 32 hospitals in the country. And next slide, please. Here you can see a photo. This was taken in Tegucigalpa, the capital of Honduras. This was a training on the LTV ventilator donated by the US government. In that same training for the correct use of the mechanical ventilator, the healthcare workers also received training in donning and doffing of PPE as a first step. This was in June, July 2020. And more than 700 healthcare workers were trained face-to-face. And you can see the high number of general doctors that were trained and nurses, and also specialists as well. Next slide, please. Well, let's not forget the IPC pillar. Looking at IPC, which is such an important pillar in our response to COVID-19, we conducted a project which was evaluation and improvement of IPC programs in 5 hospitals. We applied 2 tools, just evaluating the program in general and the hand hygiene program, and supporting IPC and quality teams in the development of improvement plans through quality tools. So this, they received support. This was done virtually. You can see on the next slide. We had a good time. You can see on the slide. It was very interesting to listen and HP Plus and these teams, IPC and quality teams, identify what were the causes of why IPC, for example, low adherence to hand hygiene in the hospital. And you can see on the left in Ichikawa diagram trying to understand why they had such a low adherence and trying to just create capacity, not only for this years that we have for COVID-19, but for preparing the country for the next pandemic, really. So this is my last slide. So now we will go to Guatemala, okay? Thank you.
Thank you, Dr. Sara Rivera. Good morning to everyone. And thank you all for bringing me the opportunity to be here with you. And merci pour mes amis qui ont parlé français aussi. Now I will bring you to a trip to the country of the eternal spring, Guatemala. So while our work has covered multiple areas in the country, I will focus principally in 3 aspects. Our work with civil society, the clinical training that we facilitated to medical doctors and nurses, and our support to government on its vaccination effort. As you can see, Guatemala is 18 million people, and we have a singular characteristics that make a great difference between El Salvador and Honduras. We have 50% of Mayan origin populations. So that's detail make that 23 indigenous languages are spoken around the country. So the other half, the Latinos, speak Spanish. So we have 24 Guatemalans in one landscape. As you see in the map, the yellow map and the red map, this is how Omicron wave spread from January to March very quickly, and practically disseminated in all the country. So that makes at the moment more than 800,000 cases and more than 70,000 deaths in Guatemala. Most of the deaths are in great cities. By now we have a coverage of vaccination very low, 54% in the first dose, 42% in the complete scheme, and 14% in the boosters. Next, please. So I will resume all that is in this chart by saying that in this slide, principally we focus in case management. That's in the 2 years of the pandemic. Case management, protocol of point of entry, hospital facility assessment and deployment of 50 ventilators that were deployed in 7 hospitals that were given by USAID, training in respiratory care, as was previously mentioned, training and prevention and infection control, that is a challenge in all our hospitals, national vaccination plan development and rollout, adverse event detection and report, and working with the government Ministry of Health about guidelines in COVID-19 management, including long-hauling COVID. And most recently, we are installed 2 simulation laboratories for respiratory training. Next, please. Okay. We have a great partnership with civil society. Thanks to this alliance, the project supported them to develop risk communications and community engagement materials. So the project trained so far 272 civil society members, principally in COVID awareness, and they help in vaccination and how to prevent the cases to spread. We make advocacy in maintaining essential health services in their community. Also, gender-based violence that it's a pop-up during the lockout in the pandemic, mental health, family planning, and food security also. The project supported targeted communications in both Spanish and indigenous language materials that raise awareness about COVID and promotion of vaccines. Next, please. This is an example of the frontline clinical training. As you see in the left and the bottom left pictures, this is Dauphin and Dunning training by an expert, and in the right, it's a training by an expert also to how to use ventilators. And we do that in 9,000 of healthcare trainings, and by means 42 workshops, webinar sessions were given in 52 hospitals of Guatemala. Next, please. In these pictures, you see the deployment of the simulator centers, and there you can see 2 our great doctors that are working in the field. Is Dr. Willy Menendez Nieves and Dr. Sofia Posadas. They are from the hospital Escuintla. It's located 50 kilometers of distance from the Guatemala city. So they are now working in the simulation center to train all the 50 hospitals in ventilations and to reduce mortality in any kind of disease that need ventilation. And I have to mention that they received the Heinemann Robinson Foundation's recognition for the best practice of intensive care teachings. Next one, please. Finally, thank you. Thank you. Finally, I would like to cover our work related to COVID vaccines. First, the project supported government in Guatemala to develop its national vaccination plan, followed by its implementations. When the government realized that they are not yielding the expected coverage, the project goes to the isolated and distant community to reach indigenous population and get vaccinated. So by means of that, we could reach more than 100% of vaccinations in some areas. And to end, I want to realize that there are many challenges that were caused by the pandemic, but I am really satisfied, and I want to thank my team that is in Guatemala and work in the field that make all these things possible. So that is not a thing that I do, it's a team completely that is in Guatemala and could be here, but I want to thank them. Thank you very much. Now, Dr. Reynaldo Flores, please.
Thank you. I would like to share with you the challenges that we had in El Salvador regarding COVID, the pandemic. You can see in the upper part of the slide the condition of the hospital. It's a public hospital in El Salvador, February 2020. You see overcrowded condition, very few health personnel. So when the pandemic started, El Salvador, with a population of 6.5 million, was in very bad shape in terms of two things. Number one, human resources, as the other two countries that presented, specialists in intensive care, and a very limited availability of beds. So for these two challenges, the government decided to build a new hospital of 500 beds for ICU. And HP Plus was required to support the training of the people in the hospital and other hospitals, and to provide through telemedicine the possibility of monitoring the patients within the hospital. So, the next one, please. I'm not going through all this detail of the milestone, but suffice to say that USAID country office was in every stage of this, of the process of these milestones during 2 years of work. And that was extremely important, because perhaps you may understand that COVID in some of the countries was a very turbulent political waters. The epidemic data, the number of deaths, the number of cases sometimes was very difficult to reach. And also the decision of the government in a specific items. So the USAID country office helped us very much in El Salvador and also in the other two countries. And I express my appreciation for that. Although you see a linear evolution during 2 years of our activities, as Nasir said very well, this technical assistance is not a linear process. It's a context-driven process. And that is very important to bear in mind. And that's, you know, reiterate the importance of USAID support. The next one, please. Okay, how HP Plus responded to the lack of personnel, trained personnel? So we, through telemedicine, we produce a monitoring center within the hospital to monitor the patients. And also we train the physician in charge of that. In that picture, you can see that the physician, very young, as Dr. Serrato indicated, physicians had in average to monitor 10 patients through the screens that they have there. So the specialists that you can see standing at the end of the picture, they were making the rounds. So through telemedicine, we did these two approaches, and also we trained around 982 physicians in the central metropolitan level. The next one, please. But we upgraded the course that we developed with the assistance of USAID, and we did two things more very important. Number one, we developed a new course, but face-to-face within the hospital, because we mobilized other resources from Japan, JICA, COICA, and Luxembourg, and they built an infrastructure within the hospital, the new hospital, And we provided the equipment for creating 2 laboratory of practice or simulation laboratory to face-to-face training. And the other part of this training was remote training with the help of the private sector that pay for the internet connection that were very bad in the rural areas. Next one. So, but the other part of our challenge was beyond the training of the physician and the monitoring, was the support to the program, the vaccination program in El Salvador. The topics that we developed for this training are the same topics, more or less, that the other countries cover, so it's in the screen. But the important thing is that we had the possibility of covering 100% of the vaccination centers and 100% of the health workers that were in charge of those vaccination centers. But again, I'm coming here to the expression, the very good expression of Francis from at the beginning of this meeting. All the success is at the local level. So the cascade training of these 5,000 people produce a training for a national level, and that is very important to underline. So, and that takes me to the last slide. Next one. Although the vaccination program in El Salvador was extremely successful, and they performed beautifully during the first month, it's a program that didn't have any shortage of vaccines. They have established the vaccination center very fast. The training of all the people was in place, and the rate of vaccination started to increase. But in September, October last year, that find a plateau, meaning that the first doses, second doses, and booster start to flatten the rate. So we developed in conjunction again with the help of USAID, the Presidential House, Minister of Health, and HP+, we developed 2 additional strategies to complete the coverage of vaccination. Still, we need to cover 1 million people from the 6.5 that I presented originally. But with these 2 strategies, the first one is a mobile vaccination centers. We train them also, and we deploy this possibility. And the second strategy is to train, as we talk, this is what's happening. We train med students in the last year of their career to cover the rest of the vulnerable population that we identify with the government. And it's important to underline that in our training, we use material from Honduras and from Guatemala. And with our activities in general term, we again received the full support of USAID country office, that I will say that was a key factor for the success of this enterprise. Thank you very much.
Slide magician, there we go. So there's 3 things. There's 3 things that we would like to leave you with on this slide. Obviously, the impressive numbers that you see speak for themselves, but I think that there's more behind numbers, right? You've seen a lot of photographs. You've met some of our staff, and as they all say, there's teams behind them, and there's teams in our office in Washington and the like. But also important, as you've heard this, is that these numbers keep going, right? So if I were to go today and look and see how many YouTube videos there were, I am sure there's more. And because of the opportunity to be able to work as a sub-partner to EPIC, because of the opportunity to have DataFi come in and provide support, you'll see that these will only continue. So when we think about sustainability and we think about localized solutions, the other thing I want to point out is out of all these healthcare workers who were trained, a number of them were trained in training of trainers. And healthcare workers stand in the hallway, just like we chat at the coffee room, they sat and chat. They have incredible stories about how they help each other with WhatsApp, what they would do to help inform things. So we will never really be able to capture the magnitude of what was done in these countries behind these numbers. But they are here because it's important, right? We're a project and we're funded and it's important. Number 2, the foundation that's been laid here We're all anticipating the potential of another surge in these countries, or coming out of a surge, or another pandemic. And this foundation that's been laid, our teams, we know now what some of the solutions are, and they know what some of the unresolved challenges are. And as we move into things like the global health security, right? So we're all hearing global health security agenda. When we're thinking about immunizations, workforce, emergency response, rapid surveillance, real-time data, there is so much of a foundation that's been laid in these programs to be able to predict, prevent, respond, and may we all recover, right? So there's that. Finally, I would like to say that as strong as these teams are, and in some countries they're the only real IP doing this work, it can't be done alone, right? So you've heard a lot about USAID. These folks and our country activity managers, they have USAID on speed dial, ministers of health, ministers in other divisions, people at the local level. It's a huge network that we can't capture that, right? But we can tell you about it. The other thing I would say that it's not just USAID and multilateral, it's those ministries, it's the ministries of health and the other ministries, the other frontline workers, community workers, people paying people's salaries. It's a whole team. We also have UCSF as a trusted partner, which helped a lot in the oxygen ecosystem and anesthesia with Mike Lipnick. Johns Hopkins University, Will Checkley in critical care, provides care at Hopkins, also speaks Spanish, helps a lot reviewing documents and supporting this team, and a multitude of others who've been able to contribute to this. So nothing in this can be done alone. But again, it's been an honor in the last 2 years to serve this team and all of the teams working at HP Plus in COVID. Thank you. So I got a lot of clothes on. I don't know if you can hear me. Oops. Hi, so we have 14 minutes. Thank you for discussion. So yes, questions, hands, questions. Yes. I'll go first with, is that David? And then to Carol, or maybe not?
Yeah. Yes. Sorry. So thanks a lot. I'm very impressed with the presentations you've presented today regarding the work you've done in Central America. Given your experience, I just wanted to know what are the actions and strategies that you see as the most important, especially now that we move forward. But I really appreciate the type of work that you have done in this region. Thank you.
Do you want to take that question, the most important actions for the region?
For the region?
Yeah.
I will say that, well, talking about sustainability, and we have a lot of added value that we need to continue supporting, and one of them is all the investment in immunization. The regular program of immunization that have a very important figures in Central America, gain a lot of equipment, gain cold chain resources, and the personnel has been upgraded in terms of knowledge of handling the vaccines, with a number of vaccines. So, and the deployment of resources in the 3 countries, I think that this is very important strategy to continue pushing and supporting, meaning the regular immunization program. Now that because of COVID, regular immunization programs upgraded all the activities, so this is one thing very important. The other thing that is a strategy that, at least for Central America, came very important is the role of USAID and the government to coordinate the agencies working for health. This is very true in the 3 countries. And the USAID officer, together with one of the technical vice minister in the country, run regular meetings with agencies related with health. This should continue. I mean, was created because of COVID, not to duplicate effort, but I will say that it's important to have all these agencies communicating each other. You will be surprised that PAHO sometimes made one thing, and I worked for PAHO for 10 years, so I know what I'm saying. UNICEF going here, Global Fund the other, although Global Fund is 40% USAID money, but IDB, the Inter-American Development Bank, and bilateral organization, they have a huge amount of resources that at least communicating what they are doing and where are they heading to is very important. So I will say that these 2 points at least we should take care in Central America.
Hello? Is it on? Thank you, and I think as Sarah said, we have a lot of lessons to learn from the great work that you did in Central America. We talked a lot about localization, and we heard a reference to it from Dr. Tesoro, and I wondered if you could talk more about that. You did the home-based care, and you talk about risk communication, but can you talk a little bit more about how you engaged local communities for local solutions to prevent or respond to COVID? Thank you.
Thank you for your question. We engage municipalities, first of all, religious leaders also, and community leaders, so, and in some cases also political leaders. Also, there are indigenous leaders that you have to engage. So this was a complete operation in each community. So this is the work that was done. It's take a little difficulties, as in some places the people wasn't so peaceful, and so we have to reach communities that the municipality was burned. So and they when the vaccination teams goes in, they literally sequestered them and destroyed the vaccine. So all this happened in several communities. So this is why the vaccinations rate in those communities is very low. If you see, you compare Guatemala City, it's more than 90% of complete vaccination. But in those communities, you reach 10 or 15%. So it's very difficult to access. They are not so peaceful, and we have to face all these troubles.
Yeah, in our case, in regards of home-based care guide, I think that not in the communications part, because in our case in Honduras, people were, very eager to receive the vaccine. So as soon as the different communications were released that the vaccine was available, people actually crowded the places and make huge lines for about 18 hours waiting for a vaccine. And I think that it was one of the things that it was quite different from Guatemala. And I understand that Guatemala, with this of 23, 24 languages in country was a major challenge for them. I would just say that in our case, and mixing a little bit of the two questions on regards of sustainability, it's about engaging also with different, specific key actors that could maintain and communicate at the community level or at the very rural or the inner parts of the country that could actually help you. I think that in Honduras, if part of it is that our first level of persons or community, rapid responses, 911, and different, it was private sector, public sector, it was civil society that carry out this message into different communities. And it was something, that we learned, not only that the public health sector had the burden, to do the responsibility to do it alone, but also that the engagement was something crucial since the very first moment. Also, in our case, for sustainability and specific purposes, we engaged the Medical College of Honduras and the Critical Care Society. We also now, we are building an engagement with the nurses, and most to the top high level, we built curriculum development to introduce them into universities so that with their master's course and diplomas, they can also gather something, a course for critical care skills and development, try to build the most that we can as, we learned that the general practitioners need to build capacity, and that was at the very first moment, the top priority for us. But I think that the engagement is also a very important thing, not to just leave it, the communication part to the health, public health sector, but also to engage all members of civil society and private sector as well.
Are there any other questions?
I want to make a,
Sorry?
may I?
Yes, I want to add something there. Go ahead.
Oh, I just adding to what Dr. Acerato mentioned, it's always a challenge to introduce new ways of achieving results. So COVID was that. It was a new scenario that nobody knew how to do things. So for us, it was a challenge because at the same time, you want to do so many things, but you want to engage all of these key actors. You want the government to lead. And most of our activities were led by the government, and we supported them. Also engaging universities, engaging medical associations. And as I mentioned earlier, it's not only thinking about how we get out of this pandemic, but actually how we prepare Honduras for the next thing that's gonna come. So specifically talking about IPC and policy development, we are now in the process of developing the first guideline for surveillance of healthcare-acquired infections. This is a topic that nobody talks about in Honduras. So our purpose is to leave this guideline so hospitals can do a good surveillance, prevent and control healthcare-acquired infections, which we don't usually talk about in COVID, but most people go into hospitals and don't really die from COVID. They die about other infections that they get, and not only talking about COVID, but in general, in any patient, right? So policy development, engaging other actors, and just engaging in the government as well, as I mentioned. I just wanted to add that.
So I think they could all answer this question, but I wanted to see if there are any other questions.
Someone's raising her hand.
Oh,
well, I think there are multiple questions.
It's very bright light. Yeah.
Thank you so much for the presentation and the wonderful job that you all done, because battling COVID and responding to it is like building flying a plane while building it, really. So, I really appreciate hearing that you also have strategies that involve working with universities to integrate curricula, COVID-related curricula, or even IPC training-related curricula into academic institutions' curricula. But the question I have is pertaining to waste management. We know that with vaccine, but even with COVID-related, COVID response and management-related waste is becoming an issue. Can you all share, or can you share with us some of your experiences in terms of how to strengthen waste management systems related to COVID management or COVID response? Thanks.
Well, I can take it.
We'll go back to Sarah and then Dr. Flores. IPC, yeah? Or Sarah, you, yeah.
Yeah, so in Honduras, we didn't really talk about that topic specifically. However, we in the IPC pillar, we did, as I mentioned before, the evaluation and strengthening of IPC programs. So the 5 hospitals, the 5 of the largest hospitals in Honduras, had the opportunity to evaluate their program and see where they needed improvement. So it was very interesting to see that one hospital, so waste management is an issue in Honduras. As I mentioned, we have no policy for waste management in Honduras. Every hospital manages the waste as they think it's best. and it's not the right way. So talking specifically about waste management, we have one hospital in Honduras, in the capital, that has a great waste management process. So from this activity that we had, another hospital had the opportunity to go and visit another hospital and see and improve and exchange ideas on how to improve the process. And I know that that hospital, from what they got from Hospital in Tegucigalpa, they have been asking for other support, other organizations to support their waste management. So the topic came into the agenda. That's what I want to say. Like it wasn't really talked about before. So everybody was doing it, and now from COVID and from the activity, they said, oh, we need this to improve. So we supported them putting it into the agenda, and that is like a huge step, right? It's not going at the end, going the whole way, but that is a huge step, and that's all I can say for waste management in my case.
Thank you. Dr. Flores.
No, first.
I make
Okay, we have 2 minutes, maybe one now. Look,
very, very quick. In infection prevention control, we in Guatemala found great differences in all hospitals and great deficiencies. Before the pandemic, our hospital system was very, very bad. Yeah, so COVID-19 hit the hospitals that were not in shape. Now they are not better right now after the pandemic. So sustainability, I think, it's only reached by means in hospitals and IPC control by knowledge. You have to educate people. This doesn't matter if the government change or anything changes, but if people know how to do, you will reach sustainability of this. Thank you.
Yes, a comment on the question. First, to say that COVID was obviously a threat and then a big problem, but also it was an opportunity for the health sector. And that opportunity, we are, taking stock on that, and we need to follow up on the critical points. Waste management was included in all our training. And obviously, with the speed of presentation, you couldn't read the part that waste management was there, and the cascade training as well. And talking about municipalities, in El Salvador, the municipal code indicates that the health of the people in the municipality is responsibility of the mayor in the municipality. And very often, the municipality pays for the health workers in the local health community. And with the cascade training, they also train the municipality. So it's an indirect way in which you can spread that kind of thing, at least in El Salvador.
We want to thank you all, and they will be here all day. And I think I'm going to turn over to Francis, but they will keep talking anytime you like, right? So thank you.
Very much.
Thank you very much, Sarah, for leading that excellent panel. Please, I think they deserve another round of applause, please. It's always interesting to hear about how countries are combating the COVID epidemic. And like Sarah said, they'll be here in the room so we can still get further insight from them that we can replicate in other countries. So with that, we come to a good place. This is the moment where we break for lunch. And there are packed lunches behind with tea and coffee and anything that you may want. So we have about 30 minutes for lunch. We'll reconvene by 1 p.m. So during lunch, you'll see at the monitors there, you'll see our impact briefs and other things that you may want to learn about. You can feel free to, have conversations and also learn from these impact briefs. So I want to thank everyone, once more for the excellent and lively discussions and contributions. And just to promise us all that the afternoon sessions will be a deeper dive into policy, governance, and financing interventions that we've done on this project. So we look forward to the afternoon session as well. Thank you for your great participation.